Recording in progress. 네, 오늘 국제 컨
Welcome to the 2023 ASEAN-ROK Infectious Disease Conference. The conference will soon begin. If you're still outside the hall, please make your way inside and take a seat. Also, please put your cell phones on vibrate or silent mode as a courtesy to others. Simultaneous interpretation is available throughout the conference. Please use the receivers at your seat and shift the channel to channel 1 for Korean and channel 2 for English.
네, 저희 잠시 후
The 2023 ASEAN-ROK Infectious Disease Conference is about to commence. Please put your cell phones on vibrate or silent mode as a courtesy to others, and as I told you, simultaneous interpretation is available throughout today's conference. Channel 1 is Korean and channel 1 is English and channel 2 is Korean.
네,
Ladies and gentlemen, the 2023 ASEAN-ROK Infectious Disease Conference will now begin. This is jointly organized by KDCA, the Mission of ROK to ASEAN, and the ASEAN Secretariat. Thank you very much for taking time out of your busy schedules to join us in person and virtually. Thank you very much for joining us today despite your very busy schedules, and welcome to the conference. This is the second edition of the Infectious Disease Conference. Allow me to introduce myself. My name is Kim Yeon-jin, and it is my delight to be your MC today. Today's conference was organized to bring together infectious disease experts and policymakers from Korea and ASEAN to share achievements and field applications of infectious disease response and to discuss future developments to strengthen joint response capabilities. It is a great pleasure to be able to hold this event in person since the pandemic. Thank you very much once again for joining us today. The conference is also being streamed live on the KDCA's YouTube channel. So please stay with us until the very end of the conference. Simultaneous interpretation is available throughout the conference. Please use the receivers on the tables and shift the channel to channel 1 for Korean and channel 1 for English and channel 2 for Korean. We are joined by many guests of honor. So now please allow me to introduce the guests of honor. Please give them a big hand when I call out their names. First and foremost, we are joined by Dr. Ji Young-mi, Commissioner of KDCA. Please give the doctor a big hand. Thank you very much for gracing us with your presence. Next, Dr. Bae Keum-ju, President of KOHAI, has joined us today. Please give her a big hand. Thank you very much. Next, thank you very much for traveling a long way to come to the conference. Professor Jung Eun-kyung of Medicine at Seoul National University College of Medicine has joined us today. Please give her a big hand. Also, we are joined by many guests of honor, and please forgive me for not being able to introduce every single guest of honor as we are pressed for time. But once they arrive, I will make sure to introduce our guests of honor, and thank you very much for joining us today. And for those of you joining us virtually, please stay with us until the very end of the conference. Now, I would like to invite our host, Dr. Ji Young-mi, Commissioner of KDCA, on the stage for her opening remarks. Please give her a big hand.
Distinguished guests, colleagues, ladies and gentlemen, I'm Young-mi Ji, Commissioner of the Korea Disease Control and Prevention Agency. I'm truly delighted to welcome you all to the 2023 ASEAN-Korea Infectious Disease Conference, co-hosted by the Korea Disease Control and Prevention Agency, the Mission of Republic of Korea to ASEAN, and ASEAN Secretariat. I wish to express my deep appreciation to Professor Gilbert Burnham, Professor Ik Eng Teo, Professor Eun Kyung-jung, Professor Jong-gu Lee for accepting the keynote speeches and all speakers and chairpersons for their valuable contribution today. I also want to thank Kohi and Seoul National University for their great support in organizing this conference. And of course, my special thanks go to the participants of the second ASEAN-ROK International Training Program, including those who participated in the online training course. During the UN high-level meeting this year, Korea strongly endorsed the political declaration on pandemic prevention, preparedness response, and will take an active part in global efforts to prevent a recurrence of problems and challenges we encountered during the COVID-19 pandemic. In May this year, the Korean government established and announced the National Pandemic Preparedness and Response Plan in collaboration with all relevant ministries. Strengthening international cooperation is a crucial component of this plan. The success of pandemic responses very much depend on ability to promptly detect and respond to potential risks identified through a robust surveillance system that will allow us to effectively collect, analyze, and share data, enabling timely decisions to address future pandemics and epidemics. In this context, I'm pleased to highlight the KDCA's contribution to ASEAN Biodiaspora, an online platform for infectious disease surveillance in the ASEAN region. This platform incorporates geographic information systems and data visualization and complementing the existing priority activities of ASEAN. It is my sincere hope that these systems within the platform will reinforce capacity for the predictive analysis of big data at the regional level, strengthening ASEAN's epidemic and pandemic preparedness and response capabilities. Equally important is our collective efforts to ensure equitable access to medical countermeasures, including vaccines and therapeutics, with a particular focus on low and middle income countries. In line with these efforts, Korea initiated a training program on vaccine and biological manufacturing targeting people from low and middle income countries as a home to the WHO's Global Biomanufacturing Workforce Training Hub. The KDCA will seek a stronger collaboration on vaccine research and development with ASEAN member states with a view to fostering global collaboration on vaccine R&D and promoting universal access. The pandemic has taught us valuable lessons, emphasizing the need to establish the resilient governance framework, securing finance, and creating effective communication tools. I do hope this conference will serve as a platform where all stakeholders share their collective wisdom to enhance the pandemic prevention, preparedness, and response capabilities in the ASEAN region. The KDCA is fully committed to ensuring the ASEAN-ROK cooperation project on capacity building for infectious diseases to produce tangible outcomes. So once again, I'd like to extend my sincere gratitude to all speakers, panelists, participants, and everyone involved in the preparation of this meeting. I wish you a very productive and successful meeting. Thank you.
Thank you very much, Commissioner of KDCA, for that kind remarks. And thank you very much for that message. And she also reiterated the importance of today's conference and hopes that this conference serves as a platform to strengthen our capacity and looks forward to a productive outcome. Thank you very much for that. Now we will hear the welcome speech. First and foremost, we will hear from Dr. Baegeum Ju, President of KOHI. Please give the President a big hand. Good afternoon, ladies and gentlemen. I am Baegeum Ju, President of KOHAI. I would like to extend a warm welcome to everyone who has joined us at the 2023 ASEAN-ROK Infectious Disease Conference. I would like to begin by extending my gratitude to Dr. Ji-young-mi, Commissioner of KDCA, Dr. Kao Keum-hoon, Secretary General of ASEAN, and Ambassador Lee Jang-geun, Ambassador of the Republic of Korea to ASEAN, for their presence. Also, my special thanks go to Professor Hong Yun-chul and Oh Joo-hwan of SNU for their support in organizing this conference. My gratitude also goes to the keynote speakers, Professor Chung Eun-kyung and Professor Lee Jong-gu of SNU and National Cancer Center, and Professor Gilbert Burnham of Johns Hopkins Bloomberg School of Public Health, who will provide valuable insight into how to respond to infectious diseases. And my gratitude also extends to other speakers and panelists. And we are also joined by the participants of the training program for the 2023 ASEAN-ROK International Training Course for Capacity Building to Infectious Disease, co-led by KOHAI and KDCA. Thank you very much for your attendance. We endured the COVID-19 pandemic for more than 3 years, and we still need to prepare for the next infectious disease and develop response strategies. I hope that the conference serves as an opportunity for ROK and ASEAN countries to collaborate effectively, nurture professionals ready to address infectious disease threats, and prepare for the future. As Korea's leading institution for training professionals in the field of health and welfare, KOHAI carries out diverse international training projects to ensure a sustainable approach to universal healthcare coverage and strengthen health security. In particular, as a body entrusted with ASEAN capacity building projects, KOHAI has been partnering with KDCA since 2022 to jointly fight infectious diseases. The second edition of the conference, which is also part of the Korean ASEAN Health Cooperation Initiative, aims to share achievements and bolster joint response capacities in fighting infectious diseases. I hope that the presentations and vibrant discussions yield fruitful results, thereby helping ROK and ASEAN further strengthen the ASEAN-Korea Health Cooperation Network. Thank you very much.
네, 고맙습니다.
Thank you very much, President Bae from KOHAI, for delivering a welcoming remarks. As mentioned, I hope that this conference, which is joined by one of you, will serve as a great opportunity for all of you involved. This is a great time that we learn and share our wisdoms for how we can best prepare ourselves for the future. So thank you, President Bae, for that great and valuable insights. Now, another round of congratulatory remarks will be delivered by Kao Keum-hoon, the Secretary General of ASEAN. Well, unfortunately, he's not with us physically, but he has sent us a pre-recorded message. So let's meet Dr. Kao Keum-hoon, please.
Excellencies, distinguished representatives, ladies and gentlemen, I'm pleased to deliver congratulatory remarks at the 2023 ASEAN-ROK International Conference on Capacity Building for Infectious Disease. I wish to commend the Republic of Korea through its Ministry of Health and Welfare and related agencies, particularly the Korea Disease Control and Prevention Agency, for convening this important thematic conference as one of the cooperative areas agreed during the first ASEAN-ROK Health Ministers meeting in May 2022 and the follow-on from the first ASEAN-ROK International Conference successfully held last year. Indeed, responding to all hazards and emerging health threats, as well as strengthening health security and health systems, remain shared priorities for ASEAN and the ROK. I believe this international conference will serve as an important platform for technical exchanges and networking among various stakeholders and international experts in further building our national and regional capacities towards effective and efficient prevention, detection, as well as response to disease outbreaks and public health emergencies. The ASEAN health sector's cooperation with the OK through the K-Health project, as organized by the OK's Ministry of Health and Welfare with related Korean agencies, is an example of sustainable cooperation around common priority areas, such as promoting resilient public health systems and enhancing universal health coverage. This cooperation is key in jointly and consistently addressing potential health crises in the region. Excellencies, distinguished representatives, ladies and gentlemen, previous public health emergencies, particularly the COVID-19 pandemic, increased the demand for more concrete collaboration to strengthen overall capacities and capabilities on infectious disease management in ASEAN. Under the ASEAN health sector, the regional public health emergency coordination was reinforced through the development of fundamental mechanisms such as the ASEAN Public Health Emergency Coordination Systems and the ASEAN Center for Public Health Emergencies and Emerging Diseases, or ACPED. Together, these serve as a springboard to facilitate mutual support and action for ASEAN and its dialogue partners and other external partners to better serve the people of ASEAN in the area of health. As the ASEAN region moves on from the pandemic, the lessons from COVID-19 and the gaps identified in responding to future hazards and emerging threats have informed new priorities in the region. On that note, the regional commitment on One Health, as supported by the ASEAN Leaders' Declaration on One Health Initiative, was adopted by the 42nd ASEAN Summit in May 2023 under the ASEAN Chairmanship of Indonesia. This key initiative defines ASEAN's priorities, health threats to humans, animals, plants, and the environment, including zoonotic pathogens, which could cause outbreaks or lead to another pandemic. By doing so, it will help guide the region's investment, research, and development in the area of prevention, preparedness, and response initiatives in ASEAN. The cross-sectoral nature of the One Health necessitated the establishment of the ASEAN One Health Network to ensure multi-sectoral collaboration and coordination among the ASEAN member states and the development of the ASEAN One Health Joint Plan of Action. In this regard, I would urge ASEAN's dialogue partners and other external partners, including the OK, to support us in our endeavors for meaningful cooperation on cross-sectoral work in the region. Excellencies, distinguished representatives, ladies and gentlemen, in closing, allow me to once again congratulate the organizers for convening this important international conference. I hope that the discussion today will not only result in the pooling of valuable lessons, but also identifying concrete steps to further strengthen the collaborative health projects between ASEAN and OK. I wish you all a very successful meeting and look forward to hearing the fruitful outcomes and productive recommendation. I thank you.
네, 박수.
Please give it up for the Secretary General. Thank you very much for the kind remarks. That was a video message sent by the Secretary General, and His Excellency talked about how he looks forward to seeing productive discussions and outcomes during this conference. Next, Ambassador Lee Jang-geun of ROK to ASEAN also sent us a video message, so please turn your attention to the screen.
His Excellency Dr. Gao Keun-pong, Secretary General of ASEAN, Her Excellency Dr. Ji Young-mi, Commissioner of Korea Disease Control and Prevention Agency, KDCA, Dr. Bae-geum-ju, President of Korea Human Resource Development Institute for Health and Welfare, Distinguished guests, ladies and gentlemen, it is a great pleasure to welcome you all to the 2023 ASEAN-ROK Infectious Disease Conference, which is organized along with the second ASEAN-ROK International Conference on Capacity Building for Infectious Disease Preparedness and Response, and the third ASEAN-ROK Health Seminar on Enhancing Health Security in Pandemic-Prone Era. Today's conference is organized by KOHAI and Seoul National University and co-hosted by KDCA, the Mission of the Republic of Korea to ASEAN and the ASEAN Secretariat. I'd like to thank the KOHAI, KDCA, and the ASEAN Secretariat for their support for this conference. On 5th May 2023, the World Health Organization announced the lifting of the public health emergency of international concern for COVID-19, which had been in place for more than 3 years since its declaration in January 2020. This means that we are all one step closer to stabilizing the COVID-19 pandemic. However, there are still uncertainties related to COVID-19, such as the occurrence of new mutations and the possibility of another new infectious disease always exists. Also, many experts predict that a new pandemic may occur in the near future. It is the reason why we must prepare for another crisis and future pandemic in times of peace. With this awareness, the Republic of Korea is keenly aware of the need for cooperation with partners. In particular, as ASEAN is geographically, socially, and economically adjacent to Korea, cooperation with ASEAN is essential in preparing and responding to infectious disease. In this regard, the Republic of Korea, together with ASEAN, is carrying out various efforts to strengthen the region's health security system. As WHO Global Training Hub for Biomanufacturing, Korea has performed on-site training for the vaccine manufacturing process for low and middle-income countries, and through this strives to ensure equal access to essential medical resources. Also, in order to strengthen infectious disease response capabilities under the leadership of the KDCA, Korea is providing international training for ASEAN member states in the fields of epidemiological investigation and laboratory diagnosis, and also supporting the operation of ASEAN Biodiaspora Virtual Center, which is the basis of infectious disease surveillance in ASEAN. Excellencies, distinguished guests, health is one of the priority areas in Korea's cooperation with ASEAN. I would like to reiterate that bolstering ASEAN's preparedness and resilience in public health emergencies is among the 8 core areas of Korea's new ASEAN Tailored Foreign Policy, KASI, Korea-ASEAN Solidarity Initiative, which was announced by Korean President Yoon Suk-yeol at the 23rd Korea-ASEAN Summit meeting in November 2022 in Cambodia. As Korea and ASEAN are set to establish a CSP, Comprehensive Strategic Partnership, next year, when we celebrate the 35th anniversary of Korea-ASEAN Partnership, we plan to continue to place high priority on the health sector in our cooperation with ASEAN. Today's conference is in line with Korea's policy focusing on health and health security in our cooperation with ASEAN. Through this conference, we hope to share Korea's experience in responding to COVID-19 with ASEAN, and also to suggest directions for strengthening cooperation in the infectious disease response, in particular in preparation for future pandemics. I expect that the establishment of a scientific and efficient infectious disease surveillance systems and prevention and response strategies for future pandemics will be broadly discussed in this conference. I hope this conference will make a meaningful contribution to laying the solid foundation for strengthening health security for resilient health systems in ASEAN in its grand journey to become epicentrum of growth in the region and beyond. Thank you very much.
네, 박수 부탁드리겠습니다.
Thank you very much. Let's give him a big round of applause. Thank you, Ambassador Lee, for sending us a pre-recorded message. Next, I would like to then move on to Mr. Shin Dong-gun, Chairman of the Health and Welfare Committee from the National Assembly. Hello everyone, my name is Shin Dong-gun, Chairman of the Health and Welfare Committee at the National Assembly of the Republic of Korea. First of all, I would like to congratulate 2023 ASEAN-ROK International Conference on Response to Infectious Disease, co-hosted by Korea Disease Control and Prevention Agency, the permanent mission of the ROK to ASEAN and Asian Secretariat. I'd also like to thank Korean Human Resource Development Institute for the Health and Welfare, or KOHI, and Seoul National University for organizing this event. Today's theme is enhancing health security in a pandemic-prone era. Despite our collective efforts to confront the turmoil and challenges posed by COVID-19, there lies more health crises on the horizon, including the threat of the emerging infectious diseases. Addressing infectious disease necessitates international collaboration and information sharing, and I trust today's conference will facilitate the enhancement of our partnerships among Korea and ASEAN member countries. As Chairman of the National Assembly's Health and Welfare Committee, I will persist in my efforts to safeguard the well-being and safety of our citizens. Thank you very much. Let's give him a big round of applause. Thank you once again, Chairman of the Health and Welfare Committee at the National Assembly, for sending us a pre-recorded message despite the busy schedule. I thank all those people in the opening ceremony. Ladies and gentlemen, I'm very happy to have all of you here, and to commemorate this event, I would like to now have a photo session. I would like to invite the VIPs from the first 3 rows to please join me on the stage so we can take a photo all together. Our staff will guide you to the stage. Please, let's join us for the group photo. Thank you.
네, 오늘 국제 컨퍼런스
Thank you very much for joining us at the conference. We will now have a group photo session, then immediately begin part 1 of the conference.
살짝 왼쪽
Can you please move to the left or right? Yes, please move to your right.
잠시 차. 네, 일단 정면 카메라 먼저 봐주실까요?
Can you please face the camera?
네,
Thank you very much, VIPs, for taking part at the group photo session. We are joined by in-person and virtual attendees. We will soon begin once we set up the stage.
네, 그럼
We will now begin part 1. But before we move to part 1, I will give you an overview of the program. Today's conference comprises of part 1 and part 2. Part 1 is titled Preparing for and Responding to Future Infectious Diseases, and part 2 will feature keynote lectures, expert presentations, and panel discussions on the topic of strengthening infectious disease surveillance. For the past 3 years, we have all fought this contagious disease called COVID-19, and in this pandemic-prone era, we still have a huge task ahead of us to safeguard the lives of the people. This conference seeks to share strategies and approaches to solve this problem. And we will propose innovative approaches to enhance health security in this pandemic-prone era and strengthen international collaboration. So please stay with us until the very end. And finally, we will also have a panel discussion and Q&A session at the end of each of the first and second sessions. For those of you attending the conference in person, please use the QR code on the back of the program booklet to upload your questions. I think it should be on the back or front. And for those of you joining us virtually, please use the YouTube chat box to upload your questions. We will do our best to entertain your questions as much as possible, and gifts will be awarded to those whose questions have been selected. So please participate in the Q&A session. Let us now begin session 1 of the 2023 ASEAN-ROK Infectious Disease Conference. Now, as I mentioned, the theme of part 1 is preparing for and responding to future infectious diseases. Please join me in welcoming Dr. Jung Eun-kyung, Professor of Medicine at SNU, and Dr. Gilbert Burnham, Professor of Medicine at Johns Hopkins University, for their keynote speeches. First, we will hear from Dr. Jung, who will talk about strengthening the infectious disease response system to prevent and respond to future pandemics. Please give her a big hand.
Good afternoon, ladies and gentlemen. My name is Jung Eun-kyung from the College of Medicine at Seoul National University. First and foremost, I would like to congratulate the opening of the 2023 ASEAN-ROK Infectious Disease Conference. We experienced COVID-19 pandemic over the past 4 years, and today is an opportunity to share the lessons and the experiences amongst the countries and talk about how best we can prepare ourselves for the next potential pandemic. So this is an extremely important and meaningful gathering. So today, I would like to talk about the following. I understand that I have 20 minutes, which is rather short. So what I can do during this time allowed to me, I can talk about the COVID-19 pandemic responses in South Korea and what we learned during this process and some of the implications. And finally, I will talk about preparedness and response of the next pandemic. So first and foremost, I would like to bring your attention to how South Korea responded to COVID-19 pandemic for the past 3 or 4 years. Now, when it comes to the response measures, we had a purpose, and which was to prevent severe cases and the deaths due to COVID-19. So that was the health aspect. We also wanted to maintain healthcare system as well as the social functions and minimize the social and economic damages caused by the COVID-19. We had 3 different phases, as you can see in the early stage. We focused on 3T, or it's also known as TTIQ, test, tracing, isolation, quarantine. And this is basically the focus of the containment, the blocking down. And after the first one, which was the community transmission phase, TTIQ was complemented by social distancing, another policy implemented by the government in order to make sure that the healthcare systems do not get compromised. And that was our way. So suppression was the focus of the community transmission phase. And during this time, vaccination and therapeutics were in development. And once they came out, we were going kind of back to the normalcy. And the third phase, which is the vaccination, was finally in place. We focused on mitigation, focusing really just on the high-risk groups where with the introduction of the vaccines and therapeutics at this time. So that's the status of the current COVID-19 in Korea. And in 2020 and 2021, so the first 2 years, you can see that it was the containment and the suppression, the first 2 focuses, in order to reduce the number of the cases. And we were pretty successful there. After the vaccine was introduced, social distancing was lifted, and then we had the Omicron, as you see at the outlier. About 67.2% of the population has been affected, that's cumulative incidence, and you can see that about 70% has a natural immunity as of recent data, and 66 out of 10,000 people, 100,000 people died. So that's the mortality rate. Of those, about 94% is about 60 years and older. Unfortunately, if you look at the death statistics in 2022, and that's when the Omicron hit the country, which was the largest number in the death. And during this time, 17.4% increase of the death rate was shown in Korea compared to the previous year. And of those people, about 8.4% of that death rate was accountable by the COVID-19, which is about 31,280. Now, the red ones, the one that has a high skyrocketing number, that's the COVID-19. And you can see in such a short period of time, it now all of a sudden goes top 3 of the death causes. And you can see that the health-wise, Korea was affected very much due to COVID-19 during the first 2 years or so. Now, let's look at the achievements and limitations. As for the achievements, I mentioned TTIQ, the quarantine measures, accompanied by the social distancing, were our first focus in order to minimize the health damage by controlling the scale and the speed of the COVID-19 pandemic. So that was successful in and of itself. And second is that the participation of the public. They were very much engaged in the personal hygiene, wearing masks on the face and washing their hands. The Korean public was very active in this. The third achievement is that there was a rapid response to the collaboration and close cooperation between central and local governments and the public health and healthcare experts. This kind of very close collaboration really led us to respond very rapidly to this pandemic. However, it was also with some limitations. I believe the biggest one being that because we had 2 years long social distancing, this had a very serious impact to the self-employed and small business owners in Korea. And also in health and education, we saw an equity problem with the gaps widening between different groups. The second limitation that we witnessed is because it was such a large number of the patients, we had lack of surge capacity to respond to pandemic, both in terms of public health as well as the healthcare system, which is why Omicron, when it hit the country, we had a very big number of the cases, and this led to the excess death and the death numbers. That's the lack of surge capacity. Now, the third limitation that we experience is the inefficient healthcare system, which means lack of control tower and etc. And another problem is the difficulties in infection control, especially in vulnerable groups. Next chapter is about our lessons and implications that we learned during the pandemic. Number one, I now have 10 of it, but let me go ahead and do one by one. And everybody in this field will agree that the risk of emerging infectious diseases will continue to persist. So it's never going to stop. So this means that we need to be able to identify potential pandemic pathogens and securing pandemic preparedness and response capabilities for each scenario is of critical importance. Second lesson is that usually you think that infectious disease crisis is only the health sector problem, and only even within the health, only the infectious disease departments. However, we learned that that's not the case. Pandemic impacts not just the health front, but society, economy, even education and religion. What this also means that when it comes to preparedness, all society must get involved, and only then we can better prepare ourselves for any kind of new pandemic. The third lesson that we learned is that, and this was actually the most challenging part during my time during the pandemic, and that is the how the pandemic affects disproportionately to vulnerable population. I mentioned about 90% or 94% of the death is from the people over 60 years and old, and most of them are actually from the high-risk groups such as the long-term facilities. So these are the people who are disadvantaged and vulnerable in terms of health. They include elderly, disabled, immune compromised people, children, pregnant women, and etc. Not only health vulnerable groups, but also socioeconomically vulnerable people such as self-employed, small business owners, care workers, platform workers, and undocumented immigrants like the workers. They were hit the hardest during the pandemic. The implications coming out of it is that not just the healthcare, but also social network must be strengthened so that we can fully prepare ourselves for the future's pandemic. So protecting those vulnerable groups, how to build and strengthen the health, not just the healthcare, but a social safety net must be an important part of our future plans. Fourth implication is that scientific evidence-based and transparent decision-making governance is a must. Only then we can have the public trust, and then we can use this and build upon this to have a great response. This will require public-private collaborative and real-time research to secure evidence and a better collaboration. We need an epidemiological and clinical research so that we have a better knowledge about this. And also based on this, we can have rapid development therapeutics and the vaccines if necessary. So this kind of scientific and transparent decision making is of great importance. The fifth lesson is that securing innovative science and technology is essential to overcome the infectious disease crisis. We were able to develop vaccines in just 1 year of the first outbreak. And what that also suggests is that the speed is important and the digital technology can be very inducive. That's why we need to secure innovative and science technology aspects of it. So that was the fifth lesson. Now the sixth lesson is that what really matters is the skilled manpower. So it's all people, the expertise, the personnel in each and every aspect must be strengthened in terms of their capabilities. Seventh point is that, like I mentioned already, transparency in terms not just in the governance, but also transportation is extremely crucial. We had this problem of infodemic, and we need to have the system to countermeasure this infodemic. The eighth lesson I would like to bring your attention to is, I guess, my second most challenging problem was the healthcare system. In particular, because we had the quarantine, the isolation, and that meant there was many immunocompromised people that are hospitalized already in the hospital. So a large number of people, when they're infected, how do we have this medical system to respond to it in order to reduce excess death is of course very important. So we needed to have medical response system to reduce excess death. Ninth point is, of course, the personal hygiene, ventilation, and infection prevention and control are very fundamental on a personal level. So this kind of routine behavioral aspects of it at school or workplaces must be routine and become internalized by everybody in our society. Last, I believe global cooperation. You will all understand that it's not just confined to one country. There are external factors. Therefore, global collaboration, global capacity building must be complemented with one another. I'm sure we all had very similar experiences in that regard. The third chapter is preparedness and response of next pandemic. So in Korea, we've had experiences of several outbreaks of the infectious disease, which had strengthened and allowed us to develop our response systems. The first one of which was 2003 SARS, and at that time, we were able to strengthen our system of the KCDC at that point, and we then also expanded isolation beds thanks to the 2003 case. Now, 2009, there was a pandemic influenza, and this is the time where we realized that we needed to stockpile antiviral drugs and PPEs. And of course, it all comes down to vaccines in order to respond to the infectious disease. So at that time, it was influenza, and we established R&D of influenza, in this case, a cell culture vaccine, and etc. And not only that, we also strengthened many of the organizations. And in that 2015, when the MERS hit the country, we realized that this was one of the largest case in Korea besides the Middle East that probably had, one of the very serious cases around the world. So at that time, we finally announced and established the National Infectious Disease Response Plan, and EOC, the Emergency Operations Center, became in place 24/7 hours, and Risk Communication Division was established. The manual was provided, and rapid diagnosis system, as well as many of the streamlined and rapid systems, were established after 2015 MERS case, and those experiences and history had actually helped us respond to the COVID even during the first stages. Now, we learned how to better respond to the COVID-19 for the past 3 or 4 years, and we've learned our lessons even from then. And based upon those lessons, we need to build a mid to long-term plans for the future so that when the next pandemic hits us, we can be better prepared for it. As for the national plan that I'm talking about, I believe our next presenter in the part 2 will be also giving you more details on that. So we don't know what the next pandemic is going to become, but based upon the 20 or maybe a century experiences, we can see that there are commonalities in the pathogens, usually zoonosis or respiratory transmission, because the easiest way to transmit, or and many variants, more like an RNA virus. So these are our expectations or predicts as to what the next pathogen is going to be. So the potential one is AI influenza or pandemic influenza. It's likely to, switch from AI to BI, or it could be another coronavirus. There are potential, possibility of those. It could be something completely different, which we call disease X, or it could be the AMR or the antimicrobial resistant. Actually, this is happening as we are speaking. So WHO or CEPI have their own priority disease list, and that they're focusing their R&Ds based upon this list, and this list is now being updated. And Korea also set its own priority diseases so that we can have our scenarios, and we're in preparation right now to make that list. So we can look at it by each and every one of the disease, but we can look at it from a viral families instead of individuals. So it can be like a mock-up vaccine. So once you have a platform, when a similar variant comes in, we can prepare better to it. So that is one scenario. So if there are, we can set the targets like you see in the slides. Now, second is that we need to have core capacities for pandemic response, and we need to first define what those capabilities must be. And we will all agree it should be prevention and preparedness, and epidemiology, lab diagnosis and healthcare system, medical responses, and the overall social safety net will probably be the 5 most important parts that make up prevention and preparedness. Now, workforce is extremely crucial, as you would agree, and DTV, the third point, is the diagnostics, therapeutics, and vaccine. And I believe one of the most important thing is that because it's usually zoonotic, one health system must be strengthened, and there's sometimes a lab issues, and biosafety net must also be enhanced. The last point in the slide you can see is a social safety net in order to protect and safeguard the vulnerable population in our society. Now, the second important capabilities is in the early detection and rapid response area. Of course, you will have to strengthen surveillance foremost. Based on what we already have, we can build upon it with syndrome surveillance, One Health surveillance, event-based surveillance, and also more stronger global surveillance system. The next point is the response governance control tower, in other words. And as mentioned already, it's not just limited or isolated to the healthcare sector. It must be a pan or whole of a society and pan-governmental approach. And political leadership is important, and scientific evidence-based and transparent decision-making is extremely critical, as well as risk communication and global governance. These are some of the extremely important core capabilities for the next pandemic. Just to give you a few details, Ministry of Health and KDCA aren't the only ones that should be responsible. In fact, Ministry of Education, Ministry of Employment, and Cultural Ministry, and all the other ministries must come together. So it's a pan-governmental collaboration, and each one of them needs to strengthen their own infectious disease response capabilities. Now, when it comes to social net, that's also very critical. We saw that the vulnerable populations in the long-term care or high-risk groups where people are gathered together, they need to be focused and prioritized. Of course, we are experiencing aging population around the world, so there are many care workers that look after these people, and how do we maintain these people and that system to strengthen these kind of vulnerable communities are of course important. And another is innovative science, technology, and R&D. Here you can see that there are different technological aspects of it, and you can see the list of it. And for each field, there is an epidemiological analysis and research needed, as well as the clinical research. And there is a therapeutics and also diagnostics. Each one of those sectors needs its own R&D. Therefore, the planning of the right R&D approach, and of course, the budgets to implement those and having the workforce is extremely crucial, which will have to come from the political leadership. And again, this cannot be done by one sector or department or country, so global collaboration would also have to be prioritized. And from our experiences, we understand the healthcare system must also be strengthened. And that is something that Korea needs to address. So there are medical and healthcare resources that are in Korea, and we need to find the best way to allocate it through a very solid control tower. This means that we need to have the governance system and right approaches. And also enhancing the critical care system, so ICU is crucial. And the primary healthcare institutions must also ramp up their ability to play a bigger role in a healthcare system. So that will be a challenge that Korea needs to address. Not only that, clinical information system and clinical research system, and also the training of the expertise must also come together. And we need to realize that it's not just a healthcare issue, it's a disaster response system that needs to be also in place. My last slide is this one. COVID-19 had not only impacted the health issue, but it was a wake-up call for everyone involved in the society. One mentioned some phrases like Corona yellow. And that there are 3 warnings involved. So first thing is that we need to learn or think more about the social value, public value, and ecological value. So these 3 values must now be prioritized now that we have learned so much from the COVID-19 pandemic. So that is it for my presentation. Thank you everyone for your attention. Thank you very much, Professor Chung, for giving us your insight through the first keynote speech. Yes, I think that Corona Yellow, the last 3 warnings were very impressive. And I understand that the mid to long-term planning is crucial for the next potential pandemic. Thanks for walking us through on the collaboration on the global stage and the strengthening of the surveillance. Thank you very much.
Next, Professor Burnham from the Bloomberg School of Public Health will deliver the second keynote speech. He was not able to join us in person, so he sent us a pre-recorded video speech. Please turn your attention to the screen.
Hello, distinguished delegates and ladies and gentlemen. It's a great pleasure to be with you today by video to discuss an area that we're all very concerned about, and that is how do we prepare for the next pandemic? We've not fully recovered from this pandemic, but we know from history and we know from basic communicable diseases that we're going to be expecting a new epidemic at some point. And what are the lessons that we've learned from this pandemic that we can apply to the next pandemic? So, of course, the world is full of the history of epidemics. There's cholera, there's plague, there's influenza, and historically, there are many epidemics that we really cannot fully identify at the present time. And not too long ago, we passed the 100th anniversary of the great influenza of 1918 through 1919, and we're still learning lessons from this. So there was a lot of interest in this epidemic during the pandemic to get an idea about what were things that we could use dealing with COVID-19. And during that time, just a couple years, we had 50 million people who died. And just a reminder that the world's population was only 2 billion people at that time. So this was much higher fatality rates than we saw with COVID-19. And since that time, we've had SARS and MERS and H5N1, Ebola, Marburg, Zika, Lassa, and finally COVID-19. And there have been plenty of others that have come along as well. And so there'll always be a next epidemic. Although for the present, COVID-19 was the big one, there'll be others coming along. And sometimes the next disease is called disease X. We don't know what it is. We don't know where it's going to be, when it's going to come. Will it be big or will it be small? But we know it's going to be there at some point. So we need to start thinking about that and allocating resources and ideas to see how we might be able to address that. So right now we're celebrating the science that went behind the development of the vaccines for COVID-19. And this epidemic we experienced killed around 7 million people and infected probably about 778 million people. Now, the vaccine not only controlled COVID-19, but it created an mRNA vaccine platform that will help us to rapidly develop future vaccines. And this in itself was a substantial achievement. And the story itself is really extraordinary, how people persisted in their vision of finding a COVID messenger RNA platform, and they worked extensively at this until they finally achieved this against many odds and considerable amount of discouragement. So this paid off in the end. We had COVID-19 vaccine, and that saved so many lives. Now, if we go back a bit, we've been studying the coronaviruses for a long time. So in many ways, this appearance of COVID-19 was not totally surprising because we knew this was a potential epidemic disease for a considerable amount of time. But even with the rapid development of the messenger RNA platform, the preparation of the vaccine itself took time, but the development of the clinical trials probably even took longer, and that was one of the delaying features. So people are thinking, are there ways around this? So when we think about the possible lessons from this experience, we can remind ourselves that even though the vaccine science has made a lot of progress and might be ready for, or not far away from, dealing with disease X, rolling out the vaccine still takes time, and much of this time is spent on the testing of human subjects. Now, there's a number of alternatives that have been proposed, and I'm not sure any of them have been firmly adopted yet, and there are proponents for all of them. Currently, we propose to develop vaccines against a variety of viruses that are candidates for causing pandemics, and some of these would be coronaviruses. And there's probably 20 families of viruses that would be able to cause something serious like this. But this would take a huge amount of money and 5 years to even be on the cusp of being ready. So far, politicians have not been so excited about this because of the huge cost and the no clear guarantee that it would bear fruit in the end. There is a scientific capacity to do this, so we should think about how could we exploit the scientific capacity to develop candidate vaccines in advance. So what have we learned? And I think I put this into about 5 categories. First off, there's the science of epidemics. So in this, we recognize that surveillance is critical, and we also recognize that we weren't doing so well with surveillance before COVID-19 sneaked up on us. We also know that there are therapeutic and non-pharmacological resources that have effectiveness as well. Some of those came fairly late in the outbreak, but these are things that could be explored further. But particularly, we need to recognize that there are risk factors, and we saw a lot about risk factors in COVID-19, and equity was a key terminology looking at the risk factors. But we also know they're changing because the environment that we're in is changing as well. Now, for my own area in public health, we have a number of messages that came from COVID-19, and one of them, unfortunately, is always expect the unexpected. Some things may just suddenly appear while being out of sight for some time during their development. So we have to be aware for that. But we also need to be aware that we need to do a better job at integrating our health workforce. We have increasing number of people in the modeling side of things, increasing number of people that are dealing with data, and bringing those people together with practitioners has been a bit difficult before COVID-19, although COVID-19 has seemed to facilitate that. So we also need to be concerned about our medicines and our supplies, because one of the things we did not do very well was the stockpiling and the availability of supplies from the stockpile. So clearly that's an area that has to be improved. Then there are areas of governance, both at the domestic and the international policy level. So we'll explore that a little bit later. And then there's the importance of having strong political leadership. And that's an example where the process fell apart on a number of occasions, so people who should show leadership in this area really didn't do very well. Just like Ebola, we saw ourselves not doing well at the communication. And we'll come back and visit these areas later on, but there are multiple areas of communication that we should have been able to do better with. And of course, there's the area of professional education. And I want to spend a little bit of the time at the end to talk about professional education, how we might be able to change curricula and methods. And in many cases, these changes have already occurred just by default during the pandemic, because we had to find a different way of doing business. So the future epidemic is almost certainly going to be a zoonotic disease of some sort, and perhaps with respiratory implications. So that's probably the leading candidate for the next disease or the next pandemic. And already we have a number of animal diseases which we know are potentially fatal among human beings, just to identify Lassa, Marburg disease, Ebola, and viral hemorrhagic fevers. All of these are potential sources of outbreaks for the future. Always, avian influenza is a major risk because it has a very unstable genetic structure and undergoes frequent mutations. So this means it could be easily transmissible from various animals or insects into human beings. So what we need also, not just for humans, but we need for viruses and organisms as well, is a surveillance system that will look for these viruses, and particularly look in animals. And the surveillance system for animals has not been developed as well as for humans, and this is an important area. And then there are areas of the food chain, and many people are concerned about an epidemic or pandemic that can be transmitted by food. And we haven't done really well with developing that type of surveillance system, both for domestic animals and for wildlife. And we also need to think about vectors. And increasingly, with climate change, vectors are moving into other areas. And in the graph on the right, we can see in the white squares or the white boxes, we can see diseases that are transmitted by vectors. So these are an important thing to think about in the future. How do we monitor the vectors affecting various parts of the human-occupied areas? And some examples here, we don't need to go into great length, but there's dengue, there's chikungunya, Japanese encephalitis with Nile virus disease. So a lot of these issues we could address by having a good surveillance for vector-borne diseases, recognizing vector-borne diseases are harder to surveil against and much more so than other types of diseases. And then we know that human beings are migrating, and as human beings are migrating, they're taking diseases with them into new areas. And finally, all over the world, we're seeing deforestation, and humans move into areas with animals, and the animals being affected by having their nutrition interfered with as the traditional stands of trees are pulled down and people move into those areas with intensive farming activities. So that puts both humans and animals at increased risk. We've talked a lot about One Health, and this has been talked about on the sidelines for a long time, but it's been hard to get One Health into the mainstream of our thinking about pandemics. And so we have to remember that epidemics or pandemics are not just confined to humans, but they also might be in animals. And having a method to carry out the surveillance among animals is really important. And particularly, these are avian organisms and with interaction with swine, because it seems that the virus is likely to move from avians to swine and undergo genetic assortment before attacking humans. So there's some potential weak areas there. So we also have to be aware of the connections between animals and humans. It's not just in the eating process. There are many other types of investigations and many other types of connections that we should be following up. Now, there's an important area for educators here. We've done a lot in education for One Health, and we've done a lot in human medicine, but these often don't interact with each other. So going forward, we need to find ways that One Health and human health programs can interact more collectively with each other. Then we have to find better ways to track pathogens. And there's some effort that's gone into tracking pathogens dealing with weaponized diseases, because there's been this great fear that smallpox would be used as a weapon, and indeed it could be. But we have other diseases such as anthrax and Yersinia pestis are all conditions which can be transmitted to humans. That can be weaponized or bioengineered. The WHO has created a scientific advisory group on the origins of novel pathogens, and this is intended to produce a global framework to help create a series of studies that will track emerging and re-emerging pathogens that might have potentially pandemic implications. So this is something else that would help us with the next epidemic to be able to think ahead. And also the idea of high-risk pathogens and how do we identify those and how do we track these more closely perhaps than middle threat pathogens or low threat pathogens. So an area that we have to keep an eye on here as well. And WHO has started this advisory group, and we look forward to it developing more strength as we move along. Now, we tend to focus a lot on pathogens such as viruses or bacteria, but we must remember that antimicrobial resistance of organisms is a major epidemiological risk, and it's been estimated to be about 700,000 deaths a year from antimicrobial resistant organisms. And these could spread to other types of organisms and could be potentially a major problem. Now, of the 700,000, perhaps a third of these are multi-drug resistant tuberculosis. But that in itself is a major threat for the future. The increasing trend of resistance to antimicrobial preparations is going to just increase with time. So we might as well just expect that. One of the problems is that there's a limited development of new antibiotics because the production of a new antibiotic from research into early production is very expensive. We're talking maybe $700 million easily in the cost of this. So we have to be careful with our antibiotics and not to encourage resistance, which will mean a demand for types of medications that we don't really have the resources to produce. And many of these problems occur in low and middle income countries in those locations where we don't have the capacity to do sensitivities on a regular basis for many organisms. So that's an area where I think international cooperation could step up and help us in these areas. Now I want to talk about the public health concerns here. So there's some basic requirements in a public health system to be sure that we can combat the outbreaks of a pandemic, one of which, of course, right up the top is equity, and we haven't done very well at that, and the way that the supplies of vaccine were managed for the outbreak of disease recently is a problem that we've seen in a number of cases. We need to have a rapid integration of data. So in many ways, the data and the workforce in the laboratories is not as clearly connected to the surveillance of disease and in humans and the preparation of treatment and treatment programs. So we need to do better there. Many countries have had these field epidemiology programs, and that's been a very successful approach, and we need to look at how do we do this more. One of the terms that we heard a lot during the COVID-19 pandemic was surge capacities, the capacities to increase the number of supplies, increase the amount of vaccines, increase the number of hospital beds in ways that we hadn't really done in the past to accommodate rapidly increasing needs. So we need to think about how can we do better in this area with the supply chain. And then finally, there's going to be increasing amounts of new technology, and how do we incorporate these quickly into managing any of the pandemics that we're dealing with. Then we think about how to improve the delivery of care. And through much of the world, primary health care is the key part of the response. In the more developed countries, we might look at primary care, which is more of a disease approach and less of a community and social approach as primary health care. But clearly, we need to look at how do we strengthen these, how do we manage to help them with combating epidemics and pandemic conditions. And then finally, what do we do about staff? We've had a lot of issues about staff. Many people have resigned. Many people have retired. There's a lot of unhappiness and burnout and substance abuse that's been brought on by dealing with the pandemic. We also think about where are our staff coming from in the future. We did a series of studies in Japan that showed that the rate limiting sector for being able to manage the COVID-19 more effectively was the number of nurses. And the number of nurses was a limiting factor to be able to address our capacities. And then finally, hospitals need to think. How do hospitals have a surge capacity? How do they look at using low intensity areas for people that have had low infection rates or lack of severity of disease? This is important. But we also learn, not only with COVID-19, but other recent pandemics, that when we're dealing with a pandemic, we're also not doing something else. And in some cases, it's taking care of maternity patients. Other cases, it's taking care of people with non-communicable diseases or other infectious diseases that need attention, but these people get ignored and isolated as a consequence of the demand of the COVID-19 pandemic for resources and human capacity. So public methods have changed. So increasingly, the public health workforce is multisectoral. Many data and systems people are now part of this activity. There's a lot more integration of data. The use of big data is an example. And One Health is just one example of how this is bringing together information from outbreaks among animals to look at what the vulnerabilities are among humans. We also know we need to be better prepared with planning. We had some early signs that we were potentially going to deal with the pandemic, but it was a problem responding to this as well as it should be. We're also having difficulties coming to grips with the fact that decentralized testing and reporting has not been done as much as we would have liked, written very nicely sometimes in science fiction books, but in practice never done at the same rate that we should be doing them in these types of emerging outbreaks of disease. And the management of disease relies a lot on the political components to support these programs. And we saw during COVID-19 that occasionally these happened, but sometimes there was a major problem with the political support for the control of COVID-19 and other related communicable diseases. And then finally, how can we communicate our data better, and also the criteria for analyzing the data and determining severity of situations and potential for growth in the near future. Now I want to say a little bit about governance, and this has been a big area just recently because we've looked at the inadequacy of our public health structure in many countries. There was criticism that the WHO was slow to get off the mark to verify that COVID-19 was a public health event of international emergency severity. So this is something that we should have addressed a little bit more rapidly and vigorously, and that's also come up for criticism. Increasingly, we're thinking about how do we enforce these types of compliance with our regulations, and probably given issues of sovereignty, we're never going to be adequately able to reinforce and enforce these specific requirements that we put out in frameworks. We have two areas that we can improve things further. The first is the international health regulations, and generally those are revised every 5 or 6 years. There's been some suggestions that maybe we should do those more frequently as new discoveries are being able to be implemented in the fight against the pandemic and other potential pandemics for the future. Another option is to create a pandemic treaty. And in fact, we've come a long ways toward that as well. So just a reminder that the international health regulations originally were very strongly oriented to regulating trade and travel, maintaining surveillance, and being sure we had lots of data. Now we're starting to think about how do we try to mandate the sharing of genetic structures and genetic analysis, which was done freely by some countries and maybe not frequently enough by other countries. We have to think about the equities in sharing things, and we have to think about ways to encourage countries to comply, because with our pandemic processes in the past, we've expected that voluntarily various people and organizations will share their data, but in fact, they really have not in many cases. And then we have to think about the financial side of things. Financials are major costs in outbreaks, and how do we improve the way that we can get money to people who need it urgently to deal with outbreaks? We can also think about the costs and how much this was and how much it's going to cost for additional vaccines and treatments. And these are some of the costs that have deterred various governments from stepping up and taking responsibility. Few governments are ready for the political consequences of a major outbreak of disease. Human health costs have soared a lot in many parts of the country, and we're asking ourselves, where does the money come from for this? There are political costs, and if a wrong decision is made politically, then the rulers are suffering a lot of accusations of not functioning appropriately. So the political trust needs to be built in a more effective way. And the political cost of doing something is bad if it's not done appropriately, and this can last for a long time. From national governments, we've been following the influenza model and the kind of zero approach to things, but now it seems that more of a focus on vaccines and mitigation would be more effective than the lockdowns, the isolation, and the other zero COVID policies that were put into place. But it's a challenge to know when we move from one stage of an outbreak to another. So some things like test, trace, and isolate work fairly well at the lower levels, but maybe they don't do so well at big national outbreaks of disease. And then we need to, of course, recognize who is vulnerable. And it took us a while during the pandemic to recognize various vulnerabilities. Some of these were occupational, some of them were income, some of them were social in nature. We also know that governments can make the commitments and take the action. And we've seen this happen in a number of places where the pandemic has been contained by good leadership from government. And let's say a little bit about communication, because this is where science meets society. So communications during the pandemic did not go particularly well, and the surveillance during Ebola and other diseases didn't go well either. So this is, in many ways, a chronic condition of not being able to communicate effectively. So we need to look at how does the health system communicate within its own leadership and health workers. So how do communications occur within the system? Because these are important to maintain the workers' skills and to keep their morale up. We had a major problem with loss of morale at this time, and also to be experimenting with new treatment theories, new treatment approaches, and new treatment theories. We also need to have better communication between public health and policymakers, because we can produce the data, but we can't always make the data in a manner that the political leadership and policymakers can quickly turn into policy. So this has hobbled us a bit. Then we have political positions that are denying the scientific base, the information that causes a lot of trouble there. And it's not clear yet how we're going to manage that, but that's an important area. And when we're thinking about how do we improve our training of our nurses and medical students and other professionals for COVID-19 in the future, we need to think about making our graduates and our students to be into better communicators in the future. And that would be going some way to communicate these new developments and new ideas. We've also found that we often didn't use some of the more effective methods that we could have, so information was moving slowly, and it was getting outdated fairly quickly as some of it became inconsistent with new developments in the management of disease and in the management of specific types of conditions. And we also found that if we work with local leadership, that has a lot more mileage and a lot more power than just working with bureaucrats who might be our partners on an intellectual and functional basis, but they don't. We can't really communicate with the politicians in the same way and communicate effectively. And we have to look at the oppositions and see how do we improve or lessen the opposition that is going on to some of the conditions that we're having to address through scientific methods. And finally, I want to say, what have we learned about professional education and epidemics? Because this hit our educational program fairly hard in some places. So it was a stress for everyone, and it really indicated that we need to have new approaches. COVID caused us to move away from some of our traditional approaches to education, which were organ-based or science-based approaches, and moved more toward IT. So many of our graduates were finishing their programs with a lot more IT skills than they had started a few years earlier. We need to be sure that we have a good longitudinal model of our educational curriculum. So when it becomes necessary to add new topics and build new competencies, we won't be so seriously overwhelmed by other activities that we'll know what to step in and do in these types of situations. We also have to learn how to practice in a disturbed system. So we're going to continue medical education for people and offer them new educational opportunities in really a disturbed system. That should be very clear by now. We're dealing with a lot of these disturbed systems. Social determinants of disease, that seems to have pinpointed many of our vulnerabilities. So certainly an approach to the various areas of vulnerability is really important in this area from the social aspect. We also know that the disease is understood differently in different community contexts, so we need to focus on understanding how our communities perceive the disease and how we can deliver our message effectively through whatever trusted traditional channels that we might have open. We also need to learn how to work from a more diverse team. This is the big message from medical and nursing education. The team at the table that's helping us to reach decisions has many more skills, and many of the people there in that team are really not health workers at all. They have interests in IT and other areas, but they need to be part of our team because they have many contributions that they can make. We have the areas of epidemiologists and modelers who are going to be more important in interacting with clinicians in the future. The data managers, the observers, and also we need to make progress in the type of trials that we do to prove the effectiveness and the safety of the new vaccines, because it's taking a long time, and there have been suggested of other approaches of it that we need to consider. We also need to remind ourselves that the community plays an important role in many of our activities, and involving them early in clinical trials can be really, really effective. And then finally on this slide, some parts of the world are more distrustful of the internet and off-site learning, and this may only increase in the future, but at the same time, we found that we can use MOOCs, we can use other off-site learning approaches, we can do virtual education, and this is going to be indispensable in the future as the workforce might be more greatly distributed across an epidemic site. And we have changes with climate, so that's going to affect a number of things. We're also going to have changes in how healthcare is provided. It's now become really expensive in some areas that we cannot continue. So that's an important area. As mentioned earlier, we need to continue our expectations of new or re-emerging diseases and be alert to these as well. We may find that we'll change the way that we physically provide assistance, and we certainly did that during the COVID-19 outbreak. So what's our new approaches? What are new technologies, vaccines, and so forth that will be still effective in our programs? And then finally, there's a problem with the distrust in science. So how do we deal with that? So we need new strategies to be able to combat rumors about the vaccines for different conditions. And then finally, how do we look at disease X at the end of these presentations? So disease X, the next unknown big epidemic disease, is coming. And we don't know where it's going to come from and how long it's going to last and where it's going to be there. We don't know what it's going to do to our thermometers as we have changes in the way that disease and febrile conditions present. So that's a concern. We need to certainly increase our surveillance. I think that's a general appreciation every place, and we need to have the science ready to investigate and respond and do so more quickly than we did with COVID-19. We're also discussing IHR, International Health Regulations, and the Pandemic Treaty. This has just come out, the Pandemic Treaties in versions 0, so a lot of work needs to be done in reviewing this. Health sector needs to communicate better. That's not been always our strength. We need to see how do we make this work more effectively. And then professional education is definitely changing. And how do we adapt our professional education to ensure that people fighting disease X, the next pandemic, will have the right skills and do the right things. So that brings us to the end of a discussion here about a few points that I think are important when we talk about the next epidemic and what we've learned from this one. And there'll be new lessons coming as we go through our great data sets and pull together our various observations. But this is the right time to do this. There are going to be a lot of rich lessons that we can apply in the future. So I'd like to thank you very much for listening to this talk, and we'd appreciate your further discussion, further ideas about what we've learned that will come to us in the future as a handy set of skills and capacities that we've developed while we've been working with COVID-19. So thank you very much, and it's been a pleasure talking with you.
Thank you very much. Please give a big hand to Professor Burnham. Thank you very much for that insightful keynote speech. Thank you very much, Professor Burnham, for the lecture. And thank you very much for taking the time out of your busy schedule to pre-record the keynote speech. Now we will move on to the next part. Now we will hear 3 presentations. First and foremost, we will hear from Mr. Jung Tong-young from the Division of Emergency Preparedness and Response in KDCA, who will talk about mid to long-term preparedness and response plan for emerging infectious diseases. Then, Mr. Chang Hee-tang, President of National Institute of Infectious Diseases, will talk about the development of vaccines and therapeutics for EIDs. Last but not least, Dr. Chung Chi-kyung will give us a lecture on how to enhance ASEAN infectious disease preparedness cooperation.
With that, I would like to invite the first speaker of this part of the conference. Let's invite Mr. Jung Tong-young from KDCA with a big round of applause. Good afternoon, distinguished guests, ladies and gentlemen. Professor Chung from SNU's College of Medicine talked about how Korea responded to the COVID-19 and lessons we learned in order to better prepare and respond to the future pandemic. So what I'm going to do, given my time, is talk about this mid to long-term plan that we have. So National Pandemic Preparedness and Response Plan that we have. So just one thing that I want to really bring your attention to is that when we talk about the emerging pandemic, the frequency and the scale of it is becoming shorter and larger, respectively. There is a modeling specific company in the UK, and according to these kind of private sector's intelligence, as well as many others, in the next 10 years or within the next 10 years, the scale of the COVID-19 or beyond of that kind of pandemic is likely to happen at the rate of 27%. But now, to prepare ourselves, we need to have the right plan and implement it. If that happens, we can reduce that to 1/3 of it, so around about 8%. Of course, it's just a result of one modeling, but I think it comes with great implications. So the issue here is how do we best prepare ourselves in order to minimize the impact that any future pandemic may have on us. So after the MERS, Korea had already set the plans and made preparations for any pandemic, which allowed us to effectively respond to the COVID-19. So thorough preparation is very important, and I don't need to re-emphasize this any further. Now the question is, how do we align it with each country, and also how do we implement this plan? So the policy support and also resources must also be in place for the plan to materialize. So please note that this plan that I'll be sharing with you is only specific to Korea, and your situation is different. So this cannot just be copied and pasted depending on the situation. But I will tell you the background, where this plan came, how this came to be, and maybe there are some commonalities where you can take into consideration when you're devising your own in your country. So in the future, our vision is to realize a safe society through agile, collaborative, and resilient emergency response to pandemic. So that again is the underlying vision on which we have three goals. Number one, secure essential medical countermeasures, including vaccine and therapeutics, within 100 or 200 days, depending on a situation. We worked together globally in order to make vaccines and therapeutics, and it took us an hour in the context of pandemic. But we want to streamline and shorten this period, so that'll be our first goal. The second goal of the national plan in Korea is to strengthen and maintain high-level response capacity for sustainable pandemic management. So the point here is the sustainability. The third goal is to prioritize the health and safety of vulnerable populations to minimize health inequalities in the society. So these are the three goals, and below that we've come up with a few principles. Number one, evidence-based decision making. Number two, proactive measures. Number three, scalable risk management. So the point here is the scalability. And the fourth one is a whole of society approach. We talked about pan-governmental, but that's not enough. We need to have a whole of a society approach. Now, these are the four basic principles, and upon this, we have 5 areas, 24 tasks, and 79 subtasks. Now, I'll be giving you a detail of 10 core tasks. So please remember that I will be skipping a few slides here and there, but there are 5 main areas. Number one, surveillance and prevention. There are 2 core tasks included, and the second area is preparedness and response. Area 3 is foundation, like a legal infrastructure, and area 4 is recovery, and number 5, research and development, or R&D. Let's first talk about the surveillance and prevention that is included in our National Pandemic Preparedness and Response Plan. We need to develop comprehensive surveillance system for early detection and infectious disease outbreaks, and this will be a very important aspect, as you would all agree. Now, if there are events happening in overseas cases, we also need to detect this. And what happens in Korea needs also to be detected early on. Right now, the foreign cases, event-based WHEIO system is already in place. However, systems like this are all English-based, and in Asia, the languages are not reflected. That's the limitation. And also when it comes to keyword selection in search, there needs to be an improvement. That's why we all live in Asia, and there are certain circumstances that needs to be better reflected in a new system. So that'll be our new goal. Second is understanding and detecting the situations in Korea. We already have surveillance method based upon and usually centered around respiratory system. We have the IRI, RSI. These are some of the surveillance, but we need to expand it and increase the number of it. This is mostly pathogen and clinical data that needs to be put in all place and implemented to strengthen the overall complementary system. The next point is that there is already like a surveillance and reporting system. But like I mentioned, we tested out many of the complementary systems. For example, wastewater surveillance system. We have this in Korea already. However, we are in making efforts to expand this wastewater system, and also wastewater in ports like seaports and airports must be in place so that we can have an early detection of pandemic. Now, this kind of system and information should not live in their own. They need to be integrated and collected so that it can be analyzed in a very smart way. That will be an important aspect of surveillance system. And you can see the various surveillance systems in Korea. Please look at the slides later on, and that can be a great reference. The second point is in regard to the multi-level government to government or international collaboration. There are various levels. Once again, it could be G2B, but not only that, the whole level collaboration on a global stage must be implemented. And I think there are areas that Korea can contribute to the global stage. There are Asian and African countries where we are helping to build capacity in those areas. And we have many projects where we share our know-how and experiences with those countries that might need assistance. Not only that, as already mentioned, WHO and many other global international organizations can also be our partners. For example, IHR and revision was already mentioned, I believe, and that's the area where Korea can play a more proactive role to advance the agenda. On top of that, last year, around December, there was a GHSA ministerial level meeting in Korea, as you remember. And the new Seoul Declaration was adopted at that occasion. And with a unanimous agreement, a GHS coordination office was established in Korea. And that office will be made into its being by the end of this year. So you can see that this is a great point where we can advance the global agenda in terms of the health. And Korea, in that regard, can play a very proactive and pivotal role. And the next point is about how we can best respond to early stage. So swift initial response to limit the spread and control the epidemic is very crucial. We need to stay away from and break away from the traditional way. And that one good example is the Q code, which is the quarantine information pre-entry system. And we also aligned it with the local governments, and we're going to continue to build upon the Q code to make it even more useful. Next is about the diagnostic capabilities. In early stages of COVID-19, we developed the diagnostic method very fast, and we also expanded to many of the public and private sectors. And we were able to therefore respond very well and very quickly. And this kind of diagnostics capabilities should be sustained so that we can prepare for the next one. And also multiplex panel and PCR-assay could also be fully utilized in order to make the diagnostics even faster and swift. Now, during the pandemic, I think we also need to have policies to support it. We had to have the approval from the MFDS, or we had to at least get the emergency use authorization, the EUA. But sometimes when the cases are very rare or minimum, there's no incentives for the companies to manufacture or develop this kind of reagent. Then in that case, public agencies like MDFS could be at the forefront of creating the reagent or testing or the diagnostic tools. LDT, or the in-house use, is a term that we use a lot in this aspect. But if there is right now, if the MFDS created a region, then it can only be used in that organization, but that needs to be fixed. So, for example, KDCA now could be at the very top, making the regions and or designating another manufacturing company, for example, to commission that work. That could be a private partner. So we need to expand this to implement effective measures for swift initial response. Not only that, we also need to have a clear understanding of the pathogens and the outbreak so that we can adapt to the trends of it. FFX, the first few case, is a protocol that is used quite a lot, and it shows the protocol to identify key epidemiological and clinical features within a short time. The question here is how to have the comprehensive information and analyze it thoroughly. So you can see we need to have a very common and consistent protocol, and we need to strengthen the system to engage all different stakeholders. If you look at the graph on the right, it's US CDC flu surge. That's the name of it. It's the predictive modeling. Now, based on the characteristics, it shows you how much resources will be used to respond. So I think we need to have a very similar system or even better one than like that one. The next one is already mentioned by Professor Chung, and that's about the surge capacity, especially in healthcare or medical sectors. We do have a high number of ICU beds or intensive care units already, and that has been extremely crucial in our response to COVID-19. However, that does not mean that we have the acute care beds, but we still need to expand the number of the ICUs. And there was some cases where it was too emergent and that we just weren't able to respond. And the question here is, there's still a controversy as to how many beds will be needed, but what was made clear during the pandemic is that almost all countries lacked enough beds, and that's the infrastructure aspect that we need to expand. Our goal in the short term is to have about 3,500 ICU beds that will need to be designated for the early response, and not just the sheer number of it, but it needs to be distributed evenly across the country, not to be concentrated in only one area. So we have the infectious disease hospitals designated at the central level, but also regional level and local level. And between the different levels of the hospitals, information and the beds availability or the patient transportation information should all be shared very clearly. And of course, compensation to the hospitals that are engaged in it will also have to be done. So here you can see we have 5 regional specialized hospitals. Right now we have 5. Our plan is to make that into 7. Now on the workforce or the manpower. Besides the public health workforce, we need to have more broader public health workforce, including epidemiologists and etc. When the Omicron variant hit the country, in most of the countries, isolation method was in fact eliminated. The question here is that if we want to effectively respond, we need to have, for example, more epidemiologists. Right now, by law, we have to have at least 1 EIOs over 100,000 population. But our goal is to make that into less than, even for population under 100,000, you still have to have an EIO. That's our plan. Right now, it's only exceeding 100,000. And the question is also the contact tracing. To what extent do we want to do this? Right now, we thought about 30 out of 100,000. That's not enough. Now, in Korea, during pandemic, we looked at about 10,000 contact tracing. And if you're talking about 30 out of 100,000, that means you have to have enough EIOs to go around. Besides that, we also believe the nursing workforce is also going to be in high demand. Next one is the long-term care facilities and other vulnerable or high-risk facilities where we saw the greatest number of the death cases. So right now, at these vulnerable situations, ventilation or the to what extent do we have this place opened up or closed, and that's something that we will going to look into more further. And also the workforce that work at these high risk facilities will have to have a stronger capacity as well. And also local government or municipalities, they are in charge of their jurisdiction, but they lack capabilities to do so, and also the trainings and having more human resources at the local government level is also critical. Now, Korea established a very robust governance structure. In fact, no matter how much capability or resources you have, if you don't have the governance, it cannot shine. But at least in Korea, we had the 4 levels of the respond. The fourth one being the most serious, the highest one, is the one on the very right under the red. Here you can see we have the headquarters, which is at the control tower. And this is led by the Prime Minister in order to have a pan-governmental structure. We have 19 ministries and 19 agencies, and they all gather together under this headquarters, including the local government. Sometimes 2,000 people gather in one given meeting. And through this kind of a governance system, we can have a very quick and transparent decision making, and we're going to build upon this. Next one is about creating an advanced information system and big data platform to improve decision-making process. We do have information, but that have been fragmented so far, and that's why we weren't able to speedily respond or analyze this kind of information. This is why we are planning to create a very integrated information system, possibly also with a big data platform. You can see here that in the past we had fragmented information about the COVID-19 and also their health checkup and etc. Again, instead of being fragmented, they will all come in one place under an integrated information platform to be analyzed. Of course, it'll have to be unidentifiable in order to keep the privacy, but still be able to use that information to analysis purposes and research purposes. And also, analysis should be done on the cloud, on the cloud level, without having to go through the other processes. Another part of this important plan is the optimizing financial and welfare support system to minimize damage and to quicken the recovery. There is the sickness benefits or invalidity sicknesses that aren't institutionalized. In Korea, we have a different history when it comes to national healthcare system or health insurance, and so in Korea we're doing the pilot of what's called the sickness benefits. This kind of benefits are available in foreign countries. Now we're trying to see how we can adapt it into Korea. So right now it's in the pilot stage. Besides that, there are again a support system that needs to become more tailored and institutionalized for different vulnerable groups, so we can include and become more comprehensive as well as very personalized. So the point here is the welfare system for the vulnerable and the marginalized. Last but not least, we will be reforming the R&D support, but on this one, another speaker is going to have more time to spend on this, so I'm just going to skip on this part. So here I've given you 10 important core tasks under the National Pandemic Preparedness and Response Plan in Korea. But of course, the most important thing is the political leadership and political support. But at the same time, budget, the financial support is of course of highest critical importance. WHO that's mentioned the establishment of the fund, and we are talking about that on the global stage as well. But not only that, within also just in the Korean context, we need to have this kind of fund and many other resources financially in order to be able to put all these great plans into action when needed. Now we can also, keep ourselves in loop for further information and updates. Thank you very much for your attention. Thank you very much, Mr. Chung from KDCA. Now I would like to invite next presenter, Mr. Chang Hee-chang, the Director General of National Institute of Infectious Disease. He's going to talk about the vaccine and therapeutics development for the novel infectious disease. Please welcome him with a big round of applause.
Thank you very much for the kind introduction. I would like to introduce myself. My name is Chang Hee-chang. I'm the DG at NIID. In 2020, from October, I have been serving as DG, and before I used to be a professor at a university hospital and provide care to the patients. Now I would like to talk about the R&D going forward, which is in the post-COVID era. Now I would like to talk about the speed, how fast should we develop, and what platform will we need to develop, and also the priority of target pathogen, and what types of cooperation will be needed, what facilities we will need going forward, as well as the funding. Now, this is the case of Korea. So prior to Omicron, the CFR was less than 1%. Or about 1%, so it was pretty high. At the time, we did not have the right therapeutics, and as former Commissioner Jung mentioned, quarantine and social distancing were the major protocols, and then we moved on to immunization, so that we can better prepare for the next phase. And then Omicron surged, and at the time we did not have quarantine or social distancing as the key preventive measures, as the disease were already widespread throughout the society. So the goal was to return to normalcy, and we adopted therapeutics, and the CFR dropped to about 0.1, but as a former commissioner mentioned, because a large number of population were infected, we did see some risks or damages in terms of death. Now, of course, we put the pandemic behind us, and we have to better prepare for the next pandemic. And in May 2023, the current commissioner unveiled the medium to long-term strategic plan against EIDs. And because Mr. Jung gave you all the details about the tasks, I will talk about the speed platform as well as the priorities of target pathogen. Then what about the speed? Now, together with KDCA, Celltrion jointly developed this very drug. It took about 14 months until the development. And the first vaccine was SKY-CoV-1, developed by SK Bioscience. And it took 28 months until the approval by KFDA. However, to better respond to the pandemics, the problem is that we do not have the therapeutics or vaccines until we have them, which is why if you look at the mid to long-term plan that we recently unveiled, this is actually the plan. So when it comes to novel pathogens, that is track 2, we give it about 6 months for the preparation. That includes preclinical and preparation and clinical trial phase 1 and 2, and up to FDA approval. So the 100 days would be prior to FDA approval, and then including the approval, this means about 6 to 7 months. That is the target. However, that could be late still, which is why when it comes to known pathogens that we are ready for or almost ready for, we need to build a library and also develop the right strategies by then. Now, of course, we need to fight the pandemic, but sometimes we need to be prepared in advance, which means that pre-pandemic era also matters. And that was part of the plan. Now, moving on the platform, what platforms will we need down the road? And these are the 2 tracks that we offer. Now, for those that we need to move fast, we call them MABs and mRNAs. We do believe that these 2 will be the essential platforms. And on top of that, when it comes to all the platforms, we do need to develop them. And while our vaccines are not mRNA, which means that although we have already developed the vaccines, but because of the variants, we were not able to apply those vaccines because mRNA is actually very susceptible to variants. So once you see the variants, you won't be able to address that easily. In that sense, MABs could be a better option. Now, I talked about MABs, and together with Celltrion, we co-developed this very drug, and about 100,000 COVID patients purchased this drug. And actually, the drugs before this, it took about 2 million Korean won to treat 1 patient, but the price for the Celltrion drug was more reasonable. It was about 400 USD per person. And we do not have an mRNA platform, which is why we do have many businesses in Korea and the government very much interested in building an mRNA vaccine platform. And it was my suggestion that we kick off a committee. And under this committee, we will inject about 10 billion Korean won to provide the support to the researchers so that they can further develop these platforms. Now, this is ST Farm, and we do believe that they have high potential to develop this mRNA platform. And we supported the animal research, which was an intramural research. So as you can see here, we provide support for these companies, and we could see high survival rate of the animals as well. Now then, I would like to talk about the target pathogen. As I mentioned before, when it comes to target pathogens, we need 2 elements to become a pandemic. First and foremost, it has to be highly infective. What I mean by that, when it comes to Ebola, it actually broke out in Africa. But then on top of that, we also need to look at the high fatality rate. Let's say that it's not quite infective, but it's fatal, then that can pose problems in specific areas. And if vice versa, we do not call that a pandemic, which is why a highly fatal pathogen and highly infective pathogen, which are mostly respiratory pathogens, well, when you mix the 2, we can say that it will be transmissible quite easily. So one case in point was MERS. And at the time, we had to respond to MERS, and that helped us fight COVID-19. However, when it comes to MERS, it was very fatal, but not that infective. So we had to keep that in mind. Now, WHO and CEPI laid out target pathogens, and we also use that as a building block. And Japan and China and Korea, we also look at SFTS, and we do see an emergence of that, and that case is about 200 in Korea, and 10 to 20% of the patients will die, and we do not have a therapeutics or vaccines for SFTS, which is why when it comes to Korea and China and Japan, we have to be the ones developing drugs or therapeutics for SFTS, which is why we have included this in the plan. Then who are we going to partner with going forward? Going forward, we cannot work alone. We're an interconnected society, so we have to work with the international community to fast-track the development of the therapeutics and vaccines. And the US NIH was quite interested in what we were doing in terms of this vaccine for SFTS. So they offered to help us, and we discussed on how we could co-develop the therapeutics. And in 2022, we actually filed for a joint patent. But in the process, we had to endure COVID-19 pandemic. So together with Celltrion, we were able to move fast in terms of developing the antibody treatments because we were able to separate the antibody fastly based on our experience and come up with MAB. So that was the experience of Korea. And at the time, the lessons learned was that global cooperation is essential to fight the pandemics. Now, together with NIID in the States, we work together, especially for SFTS therapeutics development. And we have tried to work alone, and it binds well to the pathogen, but the neutralizing agent or the development of such an agent is the challenging part, which is why we are now co-working and partnering with NIAID to be able to develop the neutralizing agent, and we have dispatched our staff for the joint R&D. And from February 2023, we have held joint symposiums. First, it was in Jeju Island, and next year, together with Japan, we plan to have the second edition of the symposium here in Incheon, thereby expand our global cooperation. Now, when it comes to the US, there is a program called PREMISE, which is to better prepare for the next pandemic. It's to obtain the blood or serum from the patients and discovering neutralizing ABs, and we create a library of the neutralizing ABs. And we do believe that that's the way forward for us as well, which is why we are following suit. And when building new facilities in the future, we will make sure that we apply this technology. Now, we have to fast track and accelerate clinical trials, which is why we have Connect in place. And we use this to accelerate clinical trials, and it follows the model of NIAID's ACT trial. And the Seoul National University Hospital joined the first trial, and now for now the two of them have been suspended, which is why going forward I want to build a more sustainable network, which is why I came up with KCOT1, which would be for severe COVID-19 cases. We are now working on the data aggregation part, and we want to engage more bodies. So together with 4 hospitals, we are working together. So when a pandemic hits, we can engage in this network to accelerate the development of therapeutics and so on and so forth. Now, we also work with Moderna. We have MAB. I talked about that partnership, and for Moderna, we are working for SFTS therapeutics. I met the leader, and in 2021 in Boston, we reached an agreement, and we will develop the antibody, and Moderna will take care of the vaccine formulation, and we plan to launch this soon. Once we actually verify that it works quite well in animals, and we also went through the challenging test, making sure that the vaccines that we developed can stop the infection of SFTS. From November, we plan to release the data to the local academic symposium, and starting from next year, we will complete the toxicity tests and discuss with Moderna in terms of how we plan to move on with the clinical trials. Then how about the facilities? What facilities do we need to invest in? It's too late to build the facilities once a pandemic hits. So I would like to re-emphasize that you need to do that in the normal times, pre-pandemic era. Now, we work with Escobayans, and it was not easy to examine all the data of the 4,037 participants, but SK and us, we were able to split that into half and look at the data, and that actually eased the workload. And next, I will skip this part. And this is the K version of Premise Project. Now, to be better prepared for the next pandemic, we have to test all the drug candidates, and we have to make sure that we develop them within 100 days. And the goal is to build a facility in Andong, and it's now a project underway. Next, to be better prepared for the next pandemic, we need to accelerate the clinical trials. Of course, we need to provide care as well as look at the data and so on and so forth. And Samsung donated about 0.7 billion USD for the next pandemic preparedness. So that was a generous donation by Samsung. And together with the National Central Hospital, we have a partnership, and they've also donated 500 million USD. And as a result, now we have a branch at SNU Hospital site, and the clinical research network that we have is is mainly driven by university hospitals. And once we operate all of them, we have no extra or plan B or backup, which is why we want to use NIID as well as the regional CDCs to install such a facility and carry out clinical trials. And once we do that, I talked about the Moderna vaccines that was jointly developed by the public sector, and adenovirus was also co-developed with the National Defense University. And when it comes to those vaccines, and when we somewhat lack the funding, we could use these facilities that I just mentioned, including the RCDC, to push the clinical trials. And for now, we have to build the physical facilities. We don't have them yet, but the university hospitals have agreed to building such a facility. So starting this week, actually Singapore has made a proposal to Korea, which was about the drug testing on a new antibiotics. So we will begin with that, and then going forward, we plan to expand the clinical trial scope with other partners. At the end of the day, the funding matters the most. This is the highest priority. This is a typo. I have one extra H here. Anyways, we tried to build on the alpha model and build on the donations from companies as well as the global funds to expand cooperative networks and build on those networks to be able to increase the funding. With that, I would like to wrap up. Thank you very much. Thank you very much, Director General, for the insightful presentation. Now we'll move on to the next presenter.
Next is Dr. Chung Chi-kyung from the Ministry of Health in Malaysia to talk about the collaboration in Asian countries. Let's welcome him.
A pleasant day to all. Allow me to share a few of the strategic measures in the ASEAN health sector that further move towards the strengthening of the capacities in the region in preparedness and response to infectious disease threats, particularly the unknowns of disease X. Slide 2, please. Allow me to share the following topics that I will go through this session. I will immediately proceed with the discussions of the rationale or the basis of the ASEAN health sector cooperation in capacity building and other programmatic interventions that will enable the region in the prevention, preparedness, detection, and response to public health threats. I will not discuss the technicalities or scenarios of a disease X that will be a possible future threat. Instead, allow me to focus on what we are doing and preparing in responding to all hazards and emerging threats. Slide 3, please. One of the sectors in the ASEAN that implements its ASEAN blueprint or roadmaps is the ASEAN health sector. This sector is currently implementing health-related strategic measures of the ASEAN Socio-Cultural Community Blueprint through the ASEAN Post-2015 Health Development Agenda, or APDA, with the guidance and support of the ASEAN health ministers, senior health officials, and various technical health experts among the ASEAN health clusters. This APDA is also aligned with the international, regional frameworks, agreements, and commitments. The APDA has 4 work programs under the respective health clusters, which envisions to achieve a healthy, caring, and sustainable ASEAN community and contribute to the implementation of the health-related strategic measures of ASEAN for 2016 to 2025. The APDA has 20 health priorities which are operationalized through more than 100 programs and projects in the respective work programs of 4 ASEAN health clusters. Through this APDA, regional work programs are implemented through the 4 ASEAN health clusters, namely Cluster 1 on promoting healthy lifestyles, Cluster 2 on responding to all hazards and emerging threats, which is the focus of today, Cluster 3 on strengthening health systems and access to care, and Cluster 4 on ensuring food safety. The regional initiatives on health security interface, prevention and control of communicable diseases, emerging or re-emerging infectious diseases, including public health emergencies and pandemics such as COVID-19 or any disease acts, are under the purview of the ASEAN Health Cluster 2 on responding to all hazards and emerging threats. Slide 4, please. With the focus on responding to all hazards and emerging threats and other risks, the ASEAN Health sector, through the ASEAN Health Cluster 2, endeavours to operationalize strategies such as 1. Enhance partnership and work together with development and dialogue partners. 2. Strengthen health capacities to enhance effective, efficient, and resilient health system. 3. Value-added coordination with relevant agencies, ministries, and local authorities. And 4. Ensure synergies between global, regional, and national level initiatives. This has been made evident in the regional response of ASEAN health sector with the rest of the non-health sectors and other external partners in our collective response to COVID-19. These operational strategies are further concretized into the following health-related initiatives in responding to public health emergencies, as well as public health impacts due to disasters, which is naturally occurring, accidental, or deliberate actions that pose serious risks to the safety of the ASEAN member states. All of the listed activities shown in this slide are operationalized through the all hazards, whole of government, and whole of society approach. These encompass the spectrum of preparedness, prevention, detection, and response measures at regional level through the paradigm of One Health approach and the One ASEAN, One Response. Slide 5, please. The Mitigation of Biological Threats Program, or MBT program in ASEAN, is one of the initiatives in the overall work program of ASEAN Health Cluster 2 on responding to all hazards and emerging threats under the ASEAN Post-2015 Health Development Agenda 2021-2025. This MBT program aims to strengthen the ASEAN capacity to mitigate a wide range of biological threats and enhance the capacity of ASEAN member states and the ASEAN region to sustain current efforts in the preparation and response to outbreaks and emerging dangerous pathogens, and in parallel, build its capacity to address biosafety and biosecurity threats. Furthermore, the MBT program supports international, regional, and national initiatives that enhance biological safety and biological security. Laboratory capacity, disease surveillance, risk assessment through big data analytics, and public health emergency preparedness and response capabilities. This program is currently supported by Global Affairs Canada. The Korea Disease Control and Prevention Agency, or KDCA, currently provides additional support to the project on big data analytics and visualization. I shall elaborate on 2 of the programs. Slide 6, please. The ASEAN Emergency Operations Center, or EOC network, for the public health emergencies through lead country Malaysia aims to 1. Enhance networking between public health EOC of all the ASEAN member states through regular video conferences and annual meetings. 2. Form an early warning mechanism through regular and rapid information sharing. 3. Support ASEAN member states in building their public health EOC capacity, including communication, information management, mobilization, coordination, and collaboration with partners as part of the National Emergency Response Network. 4. Be the platform to share expertise, lessons, and experiences in building, evaluating, exercising, and utilizing EOCs for early warning and public health emergencies response among the ASEAN member states. 5. Develop region common procedure and protocols for ASEAN member states public health EOCs while also promoting best practices and sharing lessons. And 6. To develop and administrate public health EOC training and capacity building for ASEAN member states. The ASEAN EOC network within the ASEAN health sector architecture has been functioning as the coordination platform among ASEAN member states and external partners for rapid information and technical exchanges, and capacity building and training for the ASEAN member states at the regional and national level. Slide 7, please. The ASEAN Biodiaspora Center deals with enhancing big data analytics and visualization and is operationalized through the ASEAN Biodiaspora Virtual Center, or ABVC, which serves the ASEAN region by providing risk assessment through biosurveillance of infectious diseases, epidemics, and pandemics. The ABVC monitors biological health events and emergencies that can affect the region or any ASEAN member states in its daily basis, utilizing the digital project tools or platforms such as Explorer and Insights. By project design, the ABVC is currently led by Indonesia. During the height of the COVID-19 pandemic, the ABVC, through its digital tools and AI platforms, readily produced a series of risk assessment reports on the spread of COVID-19 across ASEAN and other regions, which started as early as 20th of January 2020. As of September 2023, there are more than 500 situational reports and other publications on COVID-19 and other infectious diseases that has been produced and circulated to all ASEAN's health sector stakeholders and the public. Slide 8, please. In addition to the strategic programs initiatives that have been building the capacity of the ASEAN region in prevention, preparedness, detection, and response to the public health threats, there are also other initiatives that have been scaled up and sustained that will build upon the gains in responding to COVID-19 pandemic since 2020. There are 25 initiatives, including the previous programs that I have elaborated earlier, and these are all listed in this slide. Slide 9, please. One of the lessons in addressing the impact on COVID-19 and other past public health emergencies is the need for the regional hub in ASEAN that will address ongoing and future health threats. The ASEAN Center for Public Health Emergencies and Emerging Diseases, or ACFID, was approved to be established to serve as the center of excellence and regional resource hub to strengthen ASEAN's regional capabilities to prepare, prevent, detect, and respond to public health emergencies. Based on the endorsed scope of work, the responsibilities or functions of the ACFID is currently being hosted by Vietnam, Indonesia, and Thailand. In addition to the 3 strategic focus pillars, the ACFID would have functions that are overarching, and this would include initiatives on big data analytics, capability building, and research and development. Some of the program initiatives that I have presented earlier would be harmonized or integrated with the functions of ACFID. At the present, the 3 host countries are in the process of setting up the operations of the ACFID, while its different functions are being undertaken by the ASEAN health sector. Slide 10, please. Having shared a few of the strategic initiatives in building the capacities of the ASEAN health sector in preparing for the future health threats, such as Disease X, allow me to emphasize the need for 1. Enhancing partnership and working together towards a common end. 2. Strengthening health capacities to enhance effective, efficient, and resilient health systems. 3. Coordinating with relevant agencies, ministries, and local authorities with similar goals. And 4. Ensuring synergies of initiatives at global, regional, and national levels. And with that, next slide. Thank you very much.
네, 고맙습니다. 이렇게 해서 저희
Thank you very much for that presentation, Dr. Chung Chi-kyung. Thank you once again. Ladies and gentlemen, my clock is pointing 3:25 p.m. Probably a good time to take a coffee break. So let's take a short 5-minute break and we will resume at 3:30 Korea time. Thank you very much. So enjoy your break, 3:30, and I will see you in about 5 minutes. Thank you.
네, 여러분 저희 지금 벌써
Please come back to the hall. It's now 3:32, so I would like to ask everybody to come back to the hall. We are behind schedule, so we will begin in 1 minute. Can I please have everybody back in the room? I apologize for not being able to give you enough time to relax and recharge, but please come back to the hall and make sure that you silence your phones as a courtesy to others, and please turn off the alarms as well. We will now resume the session. Please come back to the hall and take a seat. We will soon resume the conference. Thank you very much. We will now begin session 3 or part 3.
잠깐만요. 네,
Ladies and gentlemen, I hope you had a good break. Yes, I understand that the break wasn't long, and I'm sorry about it, but we just are short of time, so we're gonna move right on to the third part of our conference. And for this, we are going to also have presenters and also panel discussions for that. And for the very first one,
갭이란 주제.
The topic is all for one, closing the gap. Professor Lee Dong-hyun and Mr. Jung Hyun-jae will first present, followed by Dr. Tama Vijaya's presentation on FETN, which is about responding to infectious diseases in ASEAN in the context of EI. And then Mr. Abdul Rahman will give a presentation on how to better respond to the infectious diseases in ASEAN. First and foremost, please join me in welcoming Professor Lee Dong-hyun up on the stage. Yes, good afternoon. As introduced, I am Lee Dong-hyun, and I'm a professor at the Grad School of Public Health at Yonsei University, and I would like to talk about the progress of our research project, which was commissioned by KOHAI, and we are in the midway. So I would like to give you some insights in the context of our perspective. Now, this is the backdrop of the research. It was to establish a regional joint response system against health crisis by improving infectious disease management policy and capacity building of field personnel. KDCA and KOHAI have commissioned us to carry out this project, and this year the Grad School of Public Health at Yonsei University was commissioned to carry this out. So now we are working on identifying the needs as well as to better understand the demand of the respondents or the people at the receiving end, and we are now planning the project, and going forward we will shift our perspective to proposing an actual model so that we can apply that model when implementing the projects. We are now identifying the demands and needs and also identifying some cases in Korea. And to that end, we carry out virtual education sessions as well as in-person virtual sessions to provide training to the recipients, and we now collect their feedback and opinions, and to that end the goal is to better respond to the next infectious diseases in Korea and ASEAN, and that is the final stage of this project. Now I will give you more details about this. Now I'll give you the big picture. This is the global ODA status. The expenditure and the demand, both of them are increasing. This is the case of Korea. Since MERS, in the past, it was about a $20 million size ODA project, but now it actually goes beyond about $100 million. And ODA projects keep expanding. And that is the trend that we see in this field. On top of that, we need to train the people better, and we need to have an educational model to that end. And WHO is also re-emphasizing the importance of training. When it comes to global TB, WHO not only proposed a training program, but as you can see here, it also provides another response network, such as the African Alert Model. And as you can see here, these are some of the programs that we have. Now, ECDC, this is the case of the EU. It has 24/7 training programs. And on top of that, together with the WHO European office, it offers various programs to better fight infectious diseases in the local regions as well as countries. And the goal is to build a training network, and ECDC is working on that. It directly provides training, and sometimes it advises other training bodies to offer such a training programs. And so far, there are about 600 programs regarding to infectious disease response. And while on MOOC, we do see some of the programs here. And in partnership with other educational institutions, the EU provides a wide variety of programs. And this is the case of USCDC, and it is also building an infectious disease surveillance network. Now, this is a case of Ethiopia and Africa, and also training programs for East European countries. And the goal is to boost the surveillance network. And the next case is USAID. Especially since COVID-19, we did see a lot of damages in Latin America, which is why the USAID is trying to build up its capacity to better respond to infectious diseases like COVID-19. So the goal is to provide localized programs. Next, this is the case of Germany. For instance, this is the case of Robert Koch Institute, or RKI. Now, it has a educational programs specifically for Armenia, and the goal is to build up capacity building, and it aims to cater to the needs of the specific needs of the country. And as you can see here, it is carrying out this type of program. Now, moving on to Japan. Now, this is what Noguchi lab is providing. It has already established a research center, and together with JICA, it serves as a regional standard lab in Africa. And with the help of JICA, the plan is to build an EI as well as surveillance network in fighting infectious diseases. Now, this is a case of ASEAN. Many of the presenters already covered what we are doing together with ASEAN, so I will be brief. Now, 9, 10 countries are part of the ASEAN countries, which means more needs or diverse needs. As you can see here, Now the laboratory and EI trainees are here, and we also identified their needs. And malaria and dengue fever, EI and surveillance and building a network locally and regionally were some of the needs that they had. At the same time, biosafety level 3 and plus laboratory building was something that they were very interested in. So that includes both EI and surveillance or laboratory. But some countries were more interested in specimen identification and transportation, as well as the analysis of the specimen. So they were more interested in finding out or learning more about each step along the way. So going forward, we will need to cater to the needs of the various needs and make sure that we build a regional network, and also to be able to think about how we can better help them build biosafety level 3 and plus laboratories in their own respective countries. So it's not just one area or one step that we need to focus on. It has to be multilateral and multi-sectoral. We have to identify the diverse needs and expand the collaborative network to that end. Which is why our program, which kicked off a few years back in 2023, we offered virtual as well as in-person training programs, especially in EI and laboratory. So EI and laboratory tracks not only offer theories and offer insight into the evaluation itself of infectious diseases, it also invites the trainings to come to Korea to take a visit, to pay a visit to the laboratories and facilities in Korea, so that later on they can carry out more intensive discussions with the experts. So we carry out different programs, and we feature diverse curricula. So as I mentioned, it's not just a one-way theory training. It's about communication and interactive sessions, and at the end of the day, how to apply theory into practice. And I believe that should be the goal of the future, and the researchers in our team are looking into that. Now, one of the areas that I would like to talk about or bring your attention to is that the national and regional level response to infectious diseases will be essential in ROK and in ASEAN. At the end of the day, sharing best practices and scalability will be key. And to share best practices, we not only need to train the practitioners and the working level staff, but it should not end there. It has to go beyond there. How can they be translated into success cases at the regional and local levels is something that we need to look at. So we need to apply that to the training. It should not just be a one-way practice session for specimen collection or analysis. It has to go beyond that. It's about scaling that up and to really think about the legal or institutional framework as well, so that going forward they can bring those two elements together and build a rigorous system in their respective countries. Next, I would like to talk about the laboratory and EI programs in more detail, and Mr. Jung Won-jae will give you more details about the two tracks. Thank you very much. Good afternoon, ladies and gentlemen. Professor Lee actually covered all the elements that I wanted to say. I feel like I will just echo what he said. Okay, so it feels awkward to stand here. Anyways, Professor Lee covered most of the parts. Anyways, Our team works with 10 ASEAN countries, and we work in EI and laboratory tracks, and we cater to the needs of the trainees. We give them training, and we learn in the process. In fact, well, the trainees are here. So I just wanted to give you a pep talk, like, we've got this. That was the message that I wanted to say. And I will just stick to my plan because I can improvise here. Anyways, this is a map familiar to you, correct? I will zoom in. These are the 10 ASEAN countries. As you can see here, the ASEAN countries share borders, which means a higher infection risk for infectious diseases. But at the same time, this also means that they have a greater opportunity to jointly respond to infectious diseases. And I would like to talk about that opportunity, not the crisis. This is the title of my presentation, and my name is Chung Won-jae. Now, these are the two tracks that we provide, EI and laboratory, and for the past few weeks, the trainers and trainees have spent an extensive amount of time to learn about EI and laboratory. Now, EI is all about identifying the transmission routes and to identifying the sources of infection. And by doing so, the plan is to prevent infectious diseases in advance. And providing the right care of service to the patient will be key to prevent further spread of the virus. And of course, ASEAN and ROK understand how important this is, which is why the two regions have been working closely together to this end. And while the trainees are the testament to the importance of this program, and they will develop the action plans and implement those action plans in their own respective countries, and that will actually be the evidence of the importance of this program as well. And dreaming of 100 is a quote that really resonates with me. When I was asked to join the program, I was quite excited. Now let's imagine we come up with the action plans, it's sustainable, and then it is scalable, and we have 10 countries in ASEAN region, and let's imagine them obtaining a total of 20 cases from both EI and laboratory. Now, this program will be a 5-year plan, and once we complete the 5-year, which this means that we will have 100 cases that we can learn from, and the premise is that we work together. So my expectation is that we hold hands and embark on this journey together, and I want us to become the hub for EI and laboratory testing for other countries. But as I mentioned, we are in dire need of your needs. What I mean by that is we need to clearly identify your needs to be able to better come up with the training programs, because otherwise we cannot cater to your needs. And we did experience failures like that in the past, which is why you need to give us a specific needs. You need to tell us what you want so that we can develop more catered and most also tailored programs to you. I love the quote, all for one. And together with the ASEAN countries, I hope that we unite for a safer world, so that we live in a world free of infectious diseases, and I hope that we go along this journey together. So please stay motivated and and when going back to your respective countries, drive change in your respective countries. Thank you very much. Thank you very much, Professor Lee Dong-hyun and Mr. Jung Hyun-jae for the presentations. Thank you very much for the insights.
Next, we also have a pre-recorded video coming from ASEAN Plus 3's FETN. And for this, we are going to listen to Dr. Paniti Tamavisaya. So let's enjoy the video.
Good afternoon, everyone. My name is Paniti Thammawijaya. I'm the senior expert in preventive medicine of the Department of Disease Control, Ministry of Public Health, Thailand, and I'm also the advisor of ASEAN Plus 3 FETN Coordinating Office. Today, it is my great pleasure to introduce you about the work of ASEAN Plus 3 FETN. First of all, I would like to thank the organizer of the 2023 ASEAN-ROK Infectious Disease Conference that, for inviting us to present in this meeting. I would like to start my presentation with talking a little bit about the ASEAN Plus 3 FETN community. ASEAN Plus 3 FETN is the network of the Field Epidemiology Training Program, or FETP, in ASEAN, 10 countries of the ASEAN, and also plus 3 countries, including China, Japan, and South Korea. We were endorsed by the 10th ASEAN Health Ministry meeting in 2010 and officially established in 2011. About our organization, the FETN is under the ASEAN Health Cluster 2, which is a part of the ASEAN Senior Official Meeting on Health Development, which can be divided into 4 clusters. And our network, FETN, is under the ASEAN Health Cluster 2. We work closely with the Secretariat of the ASEAN, and also we have the development partners that work with us, including WHO, EU, US CDC, Canada, GPP, Australian DFAT, and so on. Under the FETN, we have the FETN Steering Committee, which is comprised of the 13 member countries. And we also have the FETN Coordinating Office located in Thailand. I would like to talk a little bit more about the ASEAN Plus 3 FETN governance overview so that you can understand how we work and you can know how to collaborate with us. ASEAN Plus 3 FETN Steering Committee comprised of the chair. The chair will be taken alphabetically. And ASEAN Plus 3 FETN, we usually discuss specific annual work plan and activities in the annual steering committee meeting. And the next meeting will be held in December this year. ASEAN Plus 3 Coordinating Office plays the role of administering for preparation, implementation, and reporting to our ASEAN Plus 3 Steering Committee meeting and facility. By regular coordinate with the ASEAN Secretariat to ensure the alignment of ASEAN Plus 3 FETN work with the ASEAN Health Cluster 2 working program and strategic plan. The below diagram show the previous annual steering committee meeting and the chair of each meeting. The latest one in 2022, the chair was Brunei, and as I told you, this year Thailand is the chair. About the activity that is the main mission of the ASEAN Plus T FETN, which is capacity building for field epidemiology. We can divide our activity into 2 or 3 main activity. The first one, we have the meeting that trying to develop the policy and strategic plan. Examples of the activity in this group, including the annual ASEAN Plus T Steering Committee meeting. And we also have the annual joint meeting between FETN and also our partner from the animal health side that called AWEC, ASEAN Veterinary Epidemiology Group meeting that which is held since 2016. And we also have a meeting to develop the regional strategic plan for strengthening field epic mentorship. The latest meeting occurred in July last year. The second group is about the sharing experience and best practice and lesson learned that we frequently conduct among our network. The first one is the series of virtual technical expert and advisory panel meetings. We start this activity since the year 2021. And we also have the series of virtual experience sharing and lesson learned among the network depend on the situation of the disease. For example, last year, we have the experience sharing session for COVID-19 and also Mpox. We also conduct the seminar series with WHO support during this year several times. This is the photos of some of our previous activities. We have the annual meeting, and as you can see on the right hand side, you see that we have the virtual conference. This is virtual conference about the Mpox, which is conducted recently this year when the region identified the first few cases of Mpox. So we share the experience among the country that already identified the case and the country that still have no case at that time. We also have the activity that focus on providing the training for develop core competency or hard skill. For example, we have the joint training of trainer. We have the joint activity of the field epi work. For example, the joint dengue disease surveillance evaluation. We also provide several training workshops that add some skill to our program staff or alumni, including the workshop of the rapid assessment of transmissibility, severity, and impact on SARS-CoV. And we also have the activity to develop the curriculum and planning for rapid response team, as the field epidemiologists are one of the key members of the rapid response team. We also have the workshop to strengthen the data science capability for field epidemiology. And also, we also have the joint multi-sectoral outbreak investigation and response tabletop exercise that we work with our animal health partner to do the develop the guideline for joint investigation and response. We also have the activity that provide the soft skill for those alumni and trainees. For example, last 2 years, we have the workshop on risk communication. Last year, we have the workshop on communication to policymaker, and this year, we will have the workshop of adult learning theory for field epidemiology training. And this is also the photo of some of our previous activity. During 2021 and 2022, many activities we held virtually. And for this year, several of our workshops can work physically. In brief, our capacity building activity that focus on infectious disease preparedness and response can be divided into 3 main groups, including to develop training program and curriculum for field epidemiology, and also the activity under the heading of experience sharing. And also we provide several workshops and joint preparedness and response activity, as you can see in this summary table. Now I will talk about the proposed ASEAN cooperative strategy that we can work with ROK in the future. Strategy number 1, we are trying to intensify field epi workforce capacity and development in ASEAN plus 3 countries to ensure the sustainability of the regional epidemiology workforce. Example of the activity under this strategy including we try to utilize our field epidemiology graduates or alumni to make them work under the health security system in each country using the multilateral and multidisciplinary approach. Number 2, we try to develop several methods to train, including the hybrid field epi training and also other relevant courses to maintain and improve the capability and productivity of each field epidemiology training program. And number 3, we also strengthen the national disease surveillance by integrating digital and information technology to the field epi training. And you can see that we have some training workshop on the data science capability, and we will still continue to provide some training in this area. And the last one, we will also trying to enhance and develop the FET professional training for the new or next EID. That is the main goal of the health security agenda. Strategy number 2, we try to strengthening multi-sectoral collaboration through several interventions and through also to One Health approach. Example of the activity include the regular collaborative meeting between our group, FETN, and veterinary epidemiology group. And we also work with other professional networks in ASEAN and also in other regions as well. We try to promote the multidisciplinary joint training to strengthen field epi based on One Health approach. This year, we also trying to find the environmental partner to develop some training activity that may be benefit to our training programs in the region. We try to establish the ASEAN plus 3 field epi technical expert and advisory or TEA panels or roster, and we try to continue the dialogue among the TEA group so that we can consult or ask them when we find a new threat. And lastly, we also provide the joint mini research project grant to each country so that each country can develop the proposal and submit to the FETN, and then they can conduct some joint or mini grant activity that relevant to their health issue in the countries. And strategy number 3, to nourish efficient and effective ASEAN plus 3 FETN working and coordination mechanism in ASEAN Health Cluster 2. As we have the annual steering committee meeting every year, this is the chance that the programs can share their experience and also develop the new agenda or the new operation plan to strengthen the training program and the region as a whole. And also in the annual ASEAN plus 3 meeting, we can provide some session for the scientific conference that each FETP program can share their lesson and their performance of the student and alumni. Also, we also try to develop the new dialogue or bilateral collaborative meeting with the current and also future development partners. And the last one, we try to strengthen the ASEAN Plus T coordinating office management by trying to find the best way to manage the network and our office to serve the network as best as possible. This is the learning process that we are trying to learn from our partner and other network as well. So this is the end of my presentation. As the representative of the network, we are looking forward to work with ROK in the near future. Thank you very much.
Thank you very much for that presentation, Dr. Paniti Tamavisaya. Now, I would like to invite the next presenter.
영상으로
The next speaker also sent us a video message. Mr. Abdul Rahman will talk about how we can better fight infectious diseases in ASEAN and also make some proposal. Please turn your attention to the screen.
Ladies and gentlemen, esteemed colleagues and distinguished guests, on behalf of the Asian Biodiaspora Virtual Center, let me share with you the current status of ASEAN infectious disease response and proposal of the ASEAN cooperation strategy. Before we dive deeper into the topics, I would like to warmly welcome each of you as we gather today at the 2023 ASEAN-ROK Infectious Disease Conference. My presentation would lie on this outline, and I would like to tell you about the progress of infectious diseases globally to regionally, along with the preparedness and response, as well as the cooperation strategy. Ladies and gentlemen, esteemed colleagues and distinguished guests, I'm glad to begin my presentation today by exploring a topic of immense global significance, the global situation of infectious diseases. As we embark on this journey of understanding and knowledge sharing, we will first cast our gaze upon the broader international landscape of infectious diseases. To help us understand where and when these new infectious diseases are cropping up, the map might give us a prompt for the situation. Nowadays, we have witnessed the emergence of several infectious diseases in human population, like COVID-19, which have posed significant challenges to public health, harm the environment, and lower our quality of life. The rise of new infectious diseases, the continued presence of existing ones, and the increasing resistance of disease-causing microorganisms to antibiotics have all cast a shadow over human health. Globalization has brought about significant change in our world. It has made it easier for diseases to spread across countries and continents, putting people's health at risk. It's been over 3 years since COVID-19 was declared a public health emergency of international concern in January 2020, and it has had a profound impact on our lives. While the WHO has declared the pandemic over, COVID-19 still exists. We have seen a decrease in cases and deaths, but there are concerns about new variants like XBB.1.16 that are spreading quickly and posing a significant threat. Therefore, dealing with public health crisis is something every country and individual must face. It requires cooperation between the international community, countries, local communities, and the public. Striking a balance between daily life and protecting against diseases is an ongoing challenge. To effectively respond to these global health emergencies, it is crucial to maintain comprehensive data on infectious disease worldwide to provide sustainable monitoring in our end. Following that, we will zoom in on the current situation of infectious diseases in the ASEAN. This is a map of infectious diseases reported among ASEAN countries in 2023. All countries reported various infectious diseases ranging from emerging and re-emerging diseases. Several diseases are common among ASEAN countries, such as dengue fever, malaria, chikungunya, rabies, diphtheria, measles, and COVID-19 are also still reported. As we can see from the map, there are still cases reported to the BVC. The last update map showed that Singapore, Vietnam, Malaysia, Indonesia, and Thailand reported multiple diseases in their countries in week 40. ABPC is currently monitoring the status of COVID-19 in the ASEAN for 2023 as the WHO downgraded from a public health emergency of international concern. As of 5 October 2023, there were over 695 million cases and over 6 million deaths have been attributed to COVID-19. Globally, case fatality rate was 1.0%. Meanwhile, more than 36,000 total confirmed cases of COVID-19 have been reported in the ASEAN region. The case fatality rate in the ASEAN region was 1.0%. As COVID-19 become a regular disease and as we move out of pandemic, the IBPC continue to monitor the variant of COVID-19 that could become threat to public health in the ASEAN region and prepare ahead. Regarding mpox situation, from January to October 2023, there were 6,517 confirmed cases worldwide, including 83 people deaths. Globally, the case fatality rate was 1.27%. There are 403 confirmed cases, including one death in the ASEAN region in 2023, with a case fatality rate of 0.25%. ABPC prioritize several diseases in reporting that are relevant to the region. For vector-borne diseases, these are dengue and malaria. For dengue cases, the ASEAN region reported 7,319 new dengue cases and 3 new deaths in week 40. The case fatality rate is 0.24% from January to October 2023. For malaria disease, the ASEAN region reported 268 new malaria cases in week 40. Hence, the region reported more than 11,000 total cases and 3 total deaths in 2023 from January to October 2023. Not only vector-borne diseases, but the BPC also regularly monitor vaccine-preventable disease such as diphtheria and measles. Recently, the ASEAN region reported 102 new diphtheria cases in week 40. Therefore, the region reported 676 cases and 67 deaths in 2023 with 9.9% of case fatality rate. For measles, the ASEAN region reported 2 new measles cases in week 40. This concludes that the region have reported 4,946 total cases and 21 total deaths in 2023 with 0.42 of case fatality rate. The other disease that the BPC control are zoonotic disease like rabies. For rabies, the ASEAN region reported 653 rabies cases and 380 rabies-related deaths since January to October 2023. Now, I would like to tell you about what response were done by the ASEAN toward infectious diseases. Based on the ASEAN Public Health Emergency Framework published in 2020, there are health emergency management plans for preparedness, response, and early recovery in ASEAN, such as the designation of a national focal point for regional coordination, the ASEAN Regional Coordination Mechanism, identification of existing entities and available assets and capabilities, preparedness at point of entry, capacity building, and the last testing of preparedness mechanism. The first response was designation of a national focal point for regional coordination. In order to prepare for public health emergencies, ASEAN member state will have a national focal point to be the primary contact point for coordinating regional health sector response. ABPC has assigned a focal point based on regional training attendant that has been appointed by the respective government to enable coordination in infectious disease monitoring in the ASEAN region. The ASEAN Regional Coordination Mechanism for Public Health Emergencies will be aligned with the international health regulation with existing and upcoming ASEAN Regional Coordination System. One of ABPC function is to provide information to enhance preparedness against public health emergency. We have coordination mechanism through ASEAN Secretariat with ASEAN sectors. For national coordination, there is a designated focal point in its ASEAN member state. ABPC has direct coordination with ASEAN Network and ASEAN Secretariat, and also ASPED that will be established in the near future. Each ASEAN member state will be involved in setting up the logistical support arrangement, such as management policies, system, protocols, guidelines, and procedures, as well as a monitoring system to ensure the availability of buffer stock of commodities needed during the emergency response. ABPC provide early warning and information that will help as a member state to increase awareness and preparedness, including preparedness and logistic for response, such as vaccine and medication for treatment. The national focal point will coordinate with relevant office or agencies from other ASEAN member state and designation of entry point in case of public health emergencies, including airport, seaport, border, checkpoint, hospital, and others. ABPC information and early warning are expected to become information for preparedness at a point of entry. Strengthening the capabilities of the ASEAN member state on the appropriate response and surveillance to any public health emergencies will be ensured through risk assessment, training, development of skill, conduct of exercises, and sharing of experiences in prevention, detection, assessment, notification, and reporting of public health emergencies. ABPC provide training and capacity building on surveillance for early detection and risk assessment using big data analytics directed to ASEAN member states. National focal point may also develop through a multi-sectoral technical working group, the development and enhancement of a drill and exercise program for all ASEAN member states specific for public health emergencies. And ABPC provide the current situation and disease alert information as part of the material for the drill and exercise program for all AMS specific for public health emergencies. And in the spirit of collaboration and international solidarity and exploration of cooperation strategies might give us a light to tackle infectious disease collectively. I believe our collective insight and contribution will contribute significantly to our global understanding of infectious diseases and reinforce our commitment to safeguarding public health on a global scale. These are some proposals for cooperation that we can carry out in the near future. The first, through official data open source, sharing data and information regularly between ASEAN plus 3 for early warning and detection of pandemic or epidemic in the Asian region. Second, sharing knowledge, good practices, and lesson learned to strengthen surveillance capacity and capabilities and enhance global pandemic prevention, preparedness, and response capacity through workshop or conferences. The last is capacity building for national focal point in surveillance assessment of infectious disease through training, workshop, or conference. With this, I would like to conclude my presentation. Thank you for your attention, and I hope we can have a fruitful discussion in the near future. Thank you. Kamsahamnida.
Thank you very much for the presentation. Thank you very much, Mr. Abdurrahman. Thank you very much for your insightful presentation on how we can better respond to infectious diseases in ROK and ASEAN. We are joined by healthcare experts from home and abroad who have joined us in person and virtually. And this has offered us a great opportunity to learn more about how we can better combat the next pandemic. We will now move on to the panel discussion. The panelists will propose comprehensive ideas to build global partnerships to prepare for future pandemics and share insight into the future plans and implications for strengthening the ASEAN-ROK health cooperation. Now, this is the last session of today's Part 3 program, and I ask for your participation.
We're once again delighted to have many people in the panel discussion, and for this, we would like to invite Mr. Lee Hyun-sang from Light Foundation as a moderator. And for the panelists, we have Mr. Kwak Jin, Director of Division of International Affairs at KDCA, Professor Chun Byung-chul from Korea University School of Medicine, Professor Choi Jae-pil, Director of Infectious Disease Department of Seoul Medical Center, and Professor Choi Pyong-gyun from College of Medicine at Seoul National University. So our moderator and the 4 panelists, we like to invite all of them onto the stage for our panel discussion as the last part of the first session. So with that, let's get started with the panel discussion. Our moderator is going to lead the discussion. Hello, everyone. Thank you so much for the introduction. Well, I'm not the director just yet. I am the strategy planning director at the Light Foundation, or the Global Health Technology Research Fund. So today we're gathered here to talk about the infectious disease and the collaboration in the ASEAN context. I think the importance of the collaboration does not need any further emphasis on this. Anyways, we have 4 panelists, and due to time constraints, I'm going to go ahead and start asking the question without having to spend time on introducing our panelists, because I believe our MC had already kind of given you the introduction of who they are. So we talked about a lot of things already, and Korea has many experiences already. We've had lessons learned, and I think we've done some really remarkable things, but there are, of course, limitations that we experience. But maybe we can talk about what we can share to other Asian countries, what good things that we did during the COVID pandemic, and also some of the things that we still need to resolve, some of the issues, in other words. So what would be the experiences of Korea, both positive and negative, that can be shared with Asian countries? So that'll be the first topic of mine. So to Professor Chun, what are the important lessons learned from Korea's epidemiologic investigation and surveillance system that can be shared with the Asian region as we prepare ourselves for the next pandemic? So that is my question. What could be the important lessons from Korea that can be shared, and what are the areas that Korea could very much use the collaboration with ASEAN? Well, thank you very much for your question. My name is Chun Byung-chul, a professor at Korea University. I am very happy and delighted to be part of this important gathering. As Professor Lee and Chun already mentioned, as well as Dr. Samai and Abdulrahman, I was extremely enlightened on the lessons they offered. As all of you know, ASEAN plus 3 countries have experienced other pathogen outbreaks, and the disease X in the future is likely to first break out in these regions. Therefore, ASEAN plus 3 countries must first of all understand what are the zoonotic pathogens that are taking place now, and also this region is going to play an important role for the future as well. As our moderator pointed out, it is against this backdrop that ASEAN plus 3 must collaborate, especially against infectious disease. This could be from the surveillance all the way to the epidemiological investigation. A systematic and very structured method will have to be in place. It's not just simple sharing information or giving presentation. It should not be just for the sake of formality. Of course, that's important in and of itself, but the disease X that might break out in this region and the responses in the more very structured and specialized structure must be done. Europe is rather different. European CDC has surveillance and the training in all the European regions. However, when it comes to us, Asia, there's a political and cultural differences than Europe. So we cannot create Asian CDC, but ASEAN plus 3 countries integrated surveillance system, medical assessment, and epidemiological assessment can be done and train them together, and that's the function that we need to have in the ASEAN region. There are many threats related to infectious disease. And I think surveillance, response, and therapeutics and treatments, all these areas, capacity buildings is extremely crucial. And I personally think, though, what's most important is that no one country has the ability to deal with a disease X of the future. The situation may vary by country, but having a gathering like this today to share information and set the priorities amongst ourselves is extremely crucial, so that based upon this kind of understanding, we need to move forward with some of the actions. Now, I would think that within the ASEAN plus 3, training and workforce development of the EIOs is extremely crucial, and that's what needs to be prioritized. As Dr. Samavija mentioned, ASEAN plus 3 FETN could play an important role in this regard. Having said that, the efficacy of the training will hinge on some things. Some of the things, for example, One Health assessment is important, and that needs the sharing of your cases. However, what is more important is collecting information of this and finding out the right strategy for One Health in your own country. So training on that regard must proceed. I would think that the EIOs in the ASEAN Plus countries must be equipped to model and also find and identify the pathogens from the EI works and assess rapidly. And again, ASEAN countries and Asian countries, EIO's roles are ever more important. However, no country, even including Korea, is not equipped or it does not have us almighty EIOs. That is precisely why that experiences and expertise of the ASEAN plus 3 countries must come together to resolve this grand issue. So my first suggestion is, as our moderator mentioned, ASEAN plus 3 country level education system or training system must be established. We can call it International Epidemiology Institute, or we can just develop the FPT that we already have, FETN. And here at this institute, so-called, we can have the EIOs, and we can have the trainers of the EIOs, and those people that are properly trained can go back to their country to teach them surveillance and identification, detection of the disease X, and rapid assessment and primary prevention, and international collaboration and all that work. Training of this expertise is extremely crucial. And in each country, there are different needs and demands. Therefore, once again, we need an educational institute for vector control, crisis management, communication skills, and all that can be trained at this institute level. So that is my first suggestion. I do have more ideas, but when my next turn comes in, then I will share the rest of my suggestions. Thank you.
네, 감사합니다.
Thank you very much for that insightful suggestions and input. I think it was quite impressive, especially at the end of the day, the ASEAN CDC. Well, actually, we do not have a CDC framework like the one in Europe, which is why you emphasized on the need to collaborate and build a network. And you talked about the novel pandemic and also gave us the context of One Health and how we can build a One Health strategy. To that end, we need to analyze the data and model. Thereby, we need to bring together the professionals and also provide more rigorous training to the professionals. You also talked about the FETN training, and I believe that you also gave us insightful ideas about how we can better do in terms of EIOs. Now moving on to Professor Che De-pil. Now during COVID-19, other than Korea's disease control and diagnostic tests, including EI, what can we learn from Korea? Of course, we experienced MERS as well as other pandemics or infectious diseases on top of COVID-19, and you personally experienced a number of infectious diseases as well. So what would be your suggestion in terms of what we can suggest? So how can we be better prepared and build capacity? Thank you very much. So I am the director of Infectious Disease Department at Seoul Medical Center. This is a public medical center, and when it comes to imported diseases, we have a workforce development and medical countermeasure teams that work together to fight infectious diseases. I believe that the priority was sustainability. So let us go back to the early days. We saw this novel pathogen, and in responding to the novel pathogen, it was not easy. So if you think about COVID-19, it was not just a case in Korea, but the way we responded to COVID-19 in the ASEAN region improved over time. It was about ICUs and also containing the patients from the get-go. So we did improve on that end. But as you said, it might not be easy to diagnose disease X from day one, which is why the ASEAN Plus 3 needs to work closely to better identify novel pathogens. And we need to identify pathogens in advance, and we need to have the right capacity to do so. I think that's our number one task. And within that, we need ICUs or beds. At the same time, we also need to build the capacity to better provide care to the patients. And I believe that we have a lot to share with other ASEAN countries. Of course, we do have experience within Asia or ASEAN, but the EU has its own network. So we could identify our areas of improvement by comparing our network to that of the EU. So in terms of the organizational structure and workforce, we can do better. And number two, of course, now we experienced a pandemic. So time-wise and space-wise, the scope was wide and it was a social pandemic. And because of that, it was not a disease that one specific institution had to deal with. And if you think about COVID-19, it did not just have characteristics of an infectious disease, but as a novel infectious disease, like non-communicable disease plus COVID-19. So it was a merge between the two. Now, COVID-19, of course, we have to better examine COVID-19, but we have to better deal with NCD patients because we did have challenges in failing to care NCD patients in the past. Now, Korea is capital intensive in terms of its national characteristics. Anyways, it had to direct its resources to COVID-19 patients. And of course, over time, the country improved in providing care to NCD patients as well. But I do believe that we could do better in terms of diversification or decentralization. Now, this is something that we need to improve over time, and we still have limitations in that end, which is why, like going forward, we need to think about the context of public healthcare, how to improve that network or fight infectious diseases. Of course, we do need that, but we also need to think about the primary healthcare. So how to provide better universal healthcare to the patients, and within that network, how to provide better care to the patients. So it has to be care plus fighting infectious diseases. So we have to learn from the experience of the hospitals that treated COVID-19 patients in the early days and do better in the next pandemic era. Of course, we need to secure more facilities and so on and so forth. But from biosecurity point of view, we do have limitations. So we have to engage the community from the get-go to safeguard the lives of the people. We have to have that network to be quick on our feet. So I talked about the space and time management and Omicron, as well as Delta surge and so on and so forth. All the countries experienced those variants. So I think we should share our experiences. I think that no one country has the right answers. So is it about isolation beds, or is it about the ICU or dedicated hospitals to deal with COVID-19 patients? Or should we learn from Korea's experience in which it engaged public health centers from the get-go? So which one's the right answer? We don't know for now, but we have to learn from one another and be able to apply those lessons down the road to better prepare for the next pandemic or infectious disease. So healthcare delivery has to be right on time. We cannot accept any delays when it comes to providing healthcare services to the people. With that, I would like to wrap up.
Thank you very much. Well, COVID-19, MERS, they're not just a separate and isolated event, because we know that NCD is common in Korea and ASEAN countries. So surge capacity must be a challenge that we definitely need to address. And the question is, how do we have a holistic approach to respond to an outbreak like that? So we need to have a better and advanced care system. Of course, situations may vary on which country we're talking about, but still sharing information is of critical importance. My next question is that I understand the panel this afternoon are composed of EIOs or those that were in the public medical or healthcare center. There are also researchers in Korea universities. So you all represent those people who, as researchers or the professors, have done your share of work during the pandemic. So my next question goes to Professor Choi Pyong-gyun from Seoul National University's College of Medicine. Now, for the next future pandemic, what are the areas that Korea and ASEAN countries can collaborate in terms of research specifically? In other words, CEPI has announced its proposal for 100-day mission. In this regard, or related to this, maybe when it comes to R&D, Korea can collaborate with ASEAN. So if you can enlighten us on that, would be greatly appreciative. Hello, as introduced, I am Professor Choi Pyong-gyun from Seoul National University's College of Medicine, Department of Respiratory Disease, Infectious Disease actually. So in the early stage of the COVID-19 pandemic, I was involved in looking after the COVID-19 cases, also the severe cases or the serious cases in the early stages. And as already mentioned, NIH of the US and we, for the first time in the world, had a double-blind, a random trial. So it was an ACT trial for the first time to find therapeutics. And so these are some of the experiences related to COVID-19. As we saw the patients as a clinical doctors, we've learned many lessons, and there are some things that can be shared with ASEAN. And first and foremost, I would say whenever a pandemic breaks out, epidemiology investigation is conducted and the disease control and prevention becomes a priority. But I think what's most important are actually two pillars. Number one, we do the epidemiology and disease control and prevention to curb the spread of it, to manage it at the level that is controllable. That's one thing. But another is, in order to reduce the damage, we need to make sure that we provide the medical services to the patients. This is something that are of complete different layer, which means we need two different control towers. In Korea, though, in the early stage, the control tower was the disease control and prevention. So it was all in the prevention or control method. And that approach was used for the hospitals as well. Well, and there are some patients that did not need the treatments, and they had to be isolated until they get 2 rounds of the negative results of the PCR. In fact, what that was too much focus on the control and prevention, and the hospitals are considered as control institutes, but these should be separated. My point is that disease control versus treating the actual patients should have 2 separate control towers, and that's one lesson that we learned. Now, second is excessive anxiety or on the part of the public and on the part of medical professionals were a problem in Korea. And I think what Korean government did in order to relieve those anxiety actually backfired. What I mean is that when the first case of the COVID-19 broke out, the disease severity were unknown and medical professionals wore excessive PPEs. But at my university or the College of Medicine, wearing this kind of PPEs at an excessive level reduced the excellence of the clinical efficacy to the patients. So at the COVID-19 ward, there was the blood level that we checked, and even wearing a PPE is actually compromising the efficacy or the effectiveness of the clinical services provided from the doctors to the patients. So, of course, PPE is important, but it's important to streamline as necessary so that we can maximize the efficacy. Of course, there were anxiety, and that is the cause of it to have, for example, the excessive level of PPEs to be mandated. But I think we need to find a way to relieve that anxiety and be flexible about it in order to treat the patients better. And I've had many clinical experiences, which I think our moderator asked me to do. We had the ACT trial that Korea participated. ACT is a global initiative of 70 centers from 10 countries, and it was a large-scale clinical trial done by the NIH of the US. And it was only possible because it wasn't an ad hoc one. That group had existed for decades already, and there was a therapeutic clinical trial for antifungal and the clinical trial. The group was doing that work already for many decades. The platform existed for a while, and when the new pandemic, in this case was the COVID-19, broke out, they were already equipped with a strong platform or strong foundation, and that is how ACT could become in place so rapidly. So for clinical trial, platform is extremely crucial. And another thing that is important, we need to do it at the right place. As for the remdesivir, for example, in the U.S. and Europe, it was done in about February and March. It was also done in China around the same time. But in China, they just couldn't find the right number of patients to participate in the clinical trial. So I think what's important is that we need to find the right location with the right cases, and having the clinical trials all at the same time, simultaneously, is also going to help us to find the right clinical trial results in a timely manner. So that is the 3 lessons that I've learned from the COVID-19 pandemic. Thank you very much. So Korean experiences can become a great model, but also there are some limitations that we experience that could be shared early on so that they don't repeat it. So you're saying the excessive anxiety, which led to excessive level of responses, somehow reduce the ability to deliver the right medical services. Now, another thing about the act is that, of course, we need to be responsive, but at the same time, we need to have had a very solid system or structure already, so that when something hits, they can be utilized right away and mobilized very efficiently. So thank you very much for that suggestion.
오늘
We are pressed for time. I wish we had more time because I wanted to ask many questions, but because we're pressed for time, I won't be able to ask you multiple questions. I will now ask the final question. Actually, from KDCA, we are joined by Director Kwak Jin, who is the head of the Division of International Affairs at KDCA. And now I have a question to you. In fact, this is the question that I have to you, especially in dealing or preparing for the next pandemic. How can ROK and ASEAN better cooperate? I wanted to ask you that question, and I will elaborate on the question. Now, from a regional or local or a wider level, now let's say that the early detection of infectious diseases and sharing the data with respect to that, any institutional framework that you could propose, or how can we better propose ideas or cooperate in building such a network, especially about data sharing for infectious diseases or for microorganisms? Yes, thank you very much for that question. As introduced, I am Kwak Jin, Director of the Division of International Affairs at KDCA. Yes, I think that we have many areas where we can cooperate with ASEAN countries. We are joined by ASEAN member countries delegates, and we are actually looking into a number of ideas. First, from the ODA perspective, and more. And today, we've heard many discussions, and we also heard the keynote speeches and many presentations. And I believe that the speakers all talked about Korea's experience, and I believe that we can share that with ASEAN member countries, and that itself is quite meaningful. But first and foremost, I would like to say that let's say that we have to deal with a public health emergency situation, so it doesn't have to be a pandemic, but as we experienced that emergency, we were able to really muster up our level of preparedness, and that was of great help to all of us. For the past 20 years, we've had to deal with multiple public health situations. Sometimes it was global, sometimes it was national. And as we heard from today's presentation, there were speakers talking about SARS and novel influenza and MERS outbreak in Korea. And of course, in one in itself, they were all emergencies, but we turned the crisis into an opportunity. And we have to continue to do so in the future. And we learned our lessons from those experiences and did better the next time. And that could be a case study for all of you to learn from. So that is one message that I want to send. And going forward, I believe that we could cooperate in many other areas. We had speakers from ASEAN, and they actually covered some of these topics. And they are working very hard on that endeavor already. And one of the points that I would like to re-emphasize, it's the EOC network within the ASEAN network and FETN, which is quite active, and the biodiaspora that was mentioned before, ABVC. They are doing their job quite well. It's quite effective, but we have to maintain the level of effectiveness going forward. We have to make sure that they stay effective. And if we identify areas of support, then we need to provide more support. And we keep doing that. But we have to also understand which countries need more assistance than other countries, because some countries are doing better than their peers. So we also need to provide help and also identify some projects and initiatives through the ASEAN Secretariat, but also we are identifying some bilateral projects. For now, together with Laos, we are working on dealing with infectious diseases, and well, that was a project with Laos and KDCA, but with COIP and COICA, we are also providing a number of projects. And well, in terms of infectious disease response, it's usually focused on laboratory and EI programs. And the moderator also talked about the laboratory diagnostics capacity. And yes, we have to improve that, because that will lead to building a foundation for surveillance and also for early detection and rapid response. It really is the beginning for all these other steps or activities, which is why we have to work on the laboratory diagnostics testing, and it was a key track during this training session as well. We will continue to provide support to that, and when a member country sees an emergence of a virus, we will need to identify the virus as fast as possible and help the country to secure early detection. And to that end, we need to have the right systems and frameworks that enable such a detection. So utilizing the resources of KDCA or mobilizing the resources will be essential. And by mobilizing the resources, we will help ASEAN countries better prepare for the next pandemic or infectious disease. Last but not least, I would like to talk about the EI. As I heard the speakers' presentations, one thing drew my attention, and rapid response is, of course, a top priority, which is why we need to build a rapid response team. We have to have the right institutional framework and legal framework, and we already have the team in place. But on top of that, we also need a response, not only rapid response, but action. Because when it comes to new infectious diseases, we have to identify the characteristics of the infectious disease, or we also call it disease X. Let's say that disease X breaks out, what characteristics it has, how transmissible it is, and what else do we need to know about the specific disease, and what would be the ripple effect to other countries? Will it cross borders, and so on and so forth? These are some of the information that we need to grasp. So to that end, we will need trainings and tools. I think we do have trainings and tools within the ASEAN framework or network to a certain degree, but we need to do better. And to that end, Korea needs to provide support to the trainings and also assist the ASEAN countries in developing more modules. And that will be our job in the future. Thank you very much.
Yes, that was a very important point in the early stage, as Professor Chun mentioned, There's no such thing as Asia CDC like Europe does. So we have ASEAN or ASEAN plus 3 or Korea ASEAN. So that's kind of like a coordinated effort that is important. And it is from that perspective that Mr. Kwak just really summed up very well. Just last thing that I want to mention is that at this point, ASEAN is accumulating a lot of systems and knowledge, and this needs to be expanded further. And Korea can play a role in that expansion efforts. In particular, the diagnostics, DTV, played a very important role in Korea, and that's one thing that Korea can help ASEAN. And also rapid response is another area Korea is good. We can have technical support, or also KDCA does the ODA. There are many other ODA mechanisms already, and that can be utilized so that Korea and ASEAN can further collaborate. So thank you very much for all the panelists. Thank you. Thank you very much, everyone, for that valuable insights. So we talked about international collaboration for the future pandemic, and we also had shared information about our lessons learned and implications from the COVID-19 pandemic. And I want to thank the moderator, Mr. Lee Hyun-sang from Light Foundation, and I also want to thank the great inputs from the panelists. Let's give them another warm round of applause. Thank you once again, everyone. Now, ASEAN and Korea will need to further collaborate and coordinate on many of the issues, and I'm sure we all agree on the importance of it. The coordination efforts of these countries is actually being witnessed right here at this conference as we celebrate the second round of the conference starting from last year. We have the accumulated great system, and we can expand and deepen this collaborative efforts through more gatherings like today. So we look forward to your continued engagement. Now let's move on to the second part of today's conference, and that'll be the third ASEAN Health Seminar on the strengthening of the surveillance. And before we get started, I would like to invite Professor Hong Yun-chul from Seoul National University's College of Medicine. Let's welcome him with a big round of applause.
Thank you very much for the introduction. I'm very sorry not to have a break, but start again this session now, because we are really behind the schedule. Actually, we have talked about infectious disease response strategy and plans in ASEAN as well as in Korea. So that is a really great backdrop for further discussion. So this seminar is focusing on infectious disease surveillance capacity. So it is a little the progress from the background. So we will have two keynote speakers, but I'd like to change our schedule. So I'd like to invite Professor Igin Teo first. Briefly introducing him. He's a professor and dean of School of Public Health, National University of Singapore. Professor Teo, are you online now?
Can you hear me?
Okay, over to you, please.
Thank you very much, Chair. So good afternoon to the audience, and it is a pleasure to be invited to share some of my thoughts around how we prepare the world for the next outbreak. Now, if we start by looking at this chart, across the horizontal axis, you have a measure of importance. Vertical axis is a measure of uncertainty. So you could see that natural pathogen evolution continues to be a very important health priority, but unfortunately, this is quite uncertain whether it will create a problem. So if we look at what's happening in the world right now in the 21st century, there is clearly quite a number of mega trends. And this mega trend actually dominates what the world is supposed to look and respond. When we think about changing population demography, rapid urbanization, geopolitics, and climate changes, all of this is going to create quite a significant pressure on health systems. And unfortunately, when we set this within a pandemic era, the need to feed a growing population of 8 billion people in the world, to house 8 billion people in the world in modern cities that is rapidly urbanizing. This is when zoonotic events that we have heard previously talking about One Health in the previous panel, those are some of the pressures that the world will have to cope with, addressing some of the pandemic events that will happen. Now, we've seen COVID-19, and the earlier session talks about the ASEAN as well as the Korean response to COVID-19. But I would like to position it as a dry run for disease X. And disease X, earlier on, we heard our panelists talk about disease X. It is a infectious disease that is likely to cause a high rate of fatality, very easily infected amongst people, very easy to spread, and yet there is very little knowledge that is currently known about how do we prevent, manage, treat people with this particular condition. When COVID-19 first started back in 2020, there was this fear that COVID-19 will turn out to be a disease X, because at that point in time, we have very little knowledge. It seems to spread very quickly, but fortunately, the fatality rate, it's much lower than what we would expect of a disease X. But it became a very important dry run for governments worldwide, because we have now seen whether it is through SARS-CoV-1 or SARS-CoV-2 that infectious diseases, it's no longer a local problem. When SARS-CoV-1 happened in 2003, it very rapidly spread to different parts of the world, and we have seen that it is not just a health problem, there is a massive impact on the economy. And SARS-1 only affected the world for a period of about 3 to 4 months. Now, if we look at COVID-19, I suspect that economists are still trying to calculate what is the true economic impact to the rest of the world. Now, when I think about COVID-19 in 2023 now, what I've realized is that many world leaders have actually forgotten some of the painful lessons that we've learned from COVID-19. And they have very rapidly moved on to focus on internal politics or external geopolitics, forgetting that the commitment that they have made in the past 2-3 years around what are the preparations that countries need to invest in to prepare the world against a future outbreak like COVID-19. Now, when we saw some of the lessons that we from countries that have done well, including South Korea, including Singapore, against COVID-19, there are common lessons that we see across these different countries. In this particular paper that's published in Nature Medicine, we looked at 28 countries across the world in managing COVID-19, and we saw very clearly what were some of the factors that were necessary, including managing health services, looking after the health of the workforce in the hospitals, looking at financing approaches, and how do we engage the community to transmit the right information that the people can trust. Some of these lessons were very important and common across countries that have done well against COVID-19. And internationally, we see that every country that comes under WHO are bound by the international health regulations. And of course, we are now looking at revising and strengthening the IHR to make sure that countries are much more invested in detection, assessment, reporting, and quick response. But under the IHR, there are expectations of countries to perform. And these are just very four simple outlines of what are some of the public health functions that countries must develop within their own jurisdiction. The ability to prevent domestic and international spread, the ability to develop the necessary lab testing capability such that you are able to rapidly identify new emerging pathogens in your jurisdiction, providing the necessary field epidemiology research and investigation. Again, another point that was highlighted by the previous panel, and also the ability to respond in a multidiscipline and multi-sectorial manner whenever there is a public health emergency of international crisis. Now, when we start to think about how do countries prepare for outbreaks, we first start off with regulatory frameworks. And this is where South Korea, Singapore, we make use of parliamentary act that in the event of an outbreak happening in our countries, there are certain restrictions that will very quickly be applied to the movement of people, to the freedom of people, such that we are able to very rapidly contain the situation. And remember, the next outbreak will happen, and how we prevent an outbreak to become a pandemic, it's by national capabilities in minimizing the spread, contain it locally first. So the regulatory framework actually provides government with emergency powers to restrict movements. The next is really around strengthening the ability to perform rapid diagnostics, because this means we can very quickly test known or emerging pathogens that may have outbreak potential. And the last is really around the surveillance systems, because whether we are able to quickly identify outbreaks or pandemic potential, combine this data information to the public health alarm system such that we are very quickly able to establish the primary care surveillance system, the rapid diagnostics, or even movement restrictions and quarantine system in the population. Again, I emphasize to contain the outbreak locally. Now, in many countries, there is something that we call having this national notifiable disease surveillance, which is a very important part of the international health regulations. And under this part, this actually means that governments have a surveillance system across the entire health system, from primary care all the way to acute tertiary hospital, such that anytime there are pathogens or infection cases that are detected, there is a notification timeline that the Ministry of Health at the government level is notified that this particular primary care clinic or this government hospital or this private hospital have seen an Ebola case, and this is alerted to the highest level within the country immediately. So this reporting notifiable disease surveillance is a very fundamental part of infectious disease surveillance in any country. Now I talk about outbreak, but what are some of the priorities that countries look after when there is an outbreak happening in the country? We look at the ability to quickly identify who are the people who have been exposed. We test these people, we isolate and quarantine them if necessary. This is what we mean by contact tracing to break transmission chain. The ability to perform this, it's crucial in trying to minimize the outbreak locally. But at the same time, at the country level, we talk about minimizing the worst of an outbreak, which is the complications, the deaths that will come about. We want to make sure that hospitals are protected when there is an outbreak, that the hospitals are not swamped. We need to make sure that people's livelihood are protected, because otherwise, we have seen in some of the low and middle income countries that the reality is they can't afford to protect themselves against COVID-19 when they're faced with hunger, poverty, and starvation. So food security, water security, access to essential medical supplies, those remain very much at the heart of a national response. So when we start to think about prioritizing responses in a country, we have to make sure that our population is equitably looked after, that even the vulnerable populations are well cared for. So I talk about the ability to break chains of transmission, and this is really where the contact tracing, the testing, the ability to quickly isolate and to quarantine, what we call TTIQ, becomes important. And in this particular paper that was highlighted in PNAS back in 2017, before COVID-19 happened, we already saw the importance that was highlighted of the TTIQ procedure to be able to contact trace, because when we are able to contact trace, this is when we are able to understand the epidemiology of the outbreak much better. Will the disease spread in an asymptomatic manner? Because if you recall, it was only in March of 2020 that we had clear evidence that COVID-19 can be spread by asymptomatic people as well. So all of this knowledge around the epidemiology of an outbreak really comes from our ability to perform contact tracing at the highest level. Now, when I think about contact tracing and very rapid testing and reporting, this is where the role of fever clinics in the primary care sector becomes very important. In the event of an outbreak, do cases have, or suspected cases, have a way to report themselves to the health system? Because the symptoms will look like fever, flu-like illnesses. And how would one be able to access the necessary test and healthcare services if we want to protect the hospitals? This is where the primary care sector, or essentially fever clinics, provide a very clear form of communications to the people, to the population, that if you display the following symptoms, please do not come immediately to the hospital, but present yourself to one of these fever clinics in the primary care sector. That is a very crucial way to protect the hospitals so that they can treat the complicated cases, the severe cases. Now, we've seen that 1 year after the introduction of COVID-19, this is in January 2021, what is very striking about this map is that there are two regions in the world where the number of cases reported in a particular week remains very low. And that region is in Asia, especially in Southeast Asia and East Asia, as well as in Africa. But unfortunately, the reasons for the low number of cases in these two regions were very different. In Africa, we know right now that because they had very few testing centers or testing ability, that's why they were unable to find the cases. But in Asia, especially in East Asia, Southeast Asia, the case numbers were low because of the preparedness and the very stringent control and surveillance that were put in. I talk about contact tracing, but this was a procedure that was performed very well in countries like South Korea, in countries like Vietnam, Singapore. Now, when I think about pandemic preparedness, we immediately start thinking about global health security. And when we think about global health security, there was a benchmark that international governments actually looked at how they perform, and that is the Global Health Security Index. And I would be firm here to say that the Global Health Security Index failed catastrophically, and it actually led to perhaps even a sense of overconfidence and hubris, because we saw very clearly that the Global Health Security Index ranked the United States and the UK, the United Kingdom, as two countries that are most well prepared against an outbreak. But actually, we know for a fact, in terms of their response toward COVID-19, that they didn't do very well. And this really calls out for a reimagination of how do we determine health security? How do we measure health security properly? And this is where the IPPP actually gave a very good series of recommendations around what is important. And there is now an ongoing work that is led by the Lancet, via a Lancet commission, that is looking at what are the new ways, important ways of benchmarking pandemic preparedness that includes elements like social factors, like the trust in the population against the government, the ability of leadership at the political level to lead the country in responding against an outbreak. All of these crucial elements are important in deciding how well a country responds. And I'll just highlight this call for surveillance because there is a need for countries across different income status, not just in rich countries, but even amongst low and middle income countries to have that ability to perform surveillance. And over here, in terms of surveillance, this is where we talk about the laboratory capabilities to test. Do we have the right framework of sampling, whether it is sentinel surveillance or syndromic surveillance, at the primary care level, at the hospital level, such that there are always early warning systems that are put in place. And I'll just end off by highlighting that when we think about pandemic preparedness, it is never just about preparing a country before the outbreak happens, but what are the systems in place to help to manage an outbreak in the middle of an outbreak? Because I think in this other paper that I highlighted here, there are lessons that are learned in terms of how countries in Asia Pacific was able to lift COVID-19 restrictions, especially the closures of the borders, very successfully. And some of these lessons are important because whenever there is a movement restriction, whether it is local movement restriction or a closure of borders internationally to minimize movement of people, livelihoods, the economy will be affected, and that prolongs the burden on the health sector. So in summary, I think the world is facing a pandemic era, so we will see future outbreaks, and whether those future outbreaks can be minimized and handled locally without progressing to become a pandemic really depends on the ability of national, subnational, regional capabilities to survey, to perform the necessary surveillance, to prepare the population in terms of the necessary personal protective equipment, as well as to put in place the necessary infection prevention and control strategies. The way that we measure pandemic readiness and preparedness have to change, and even changing beyond what is currently used as existing frameworks, including the joint external evaluation that is being conducted internationally. So I think I actually believe that countries, public health practitioners, we know what is necessary. But the question is, do the political leadership know it and is keen to invest in it? And I think that is a major uncertainty at the moment. So with that, thank you very much. And it's a real honor and pleasure to be invited to speak today. Thank you very much. And back to the chair.
Professor, thank you very much. I really believe that Singapore set a really good model about how to respond to the pandemic, or actually DGX coming soon anytime. Thank you very much again. 두 번째 스피커를
Let me invite our second presenter.
두 번째
Now the second keynote speaker is a person that you know very well, and this person used to serve as the commissioner of KCDC, which is the predecessor of KDCA.
The honor to be in charge of the presentation. I am the Jung Lee, the former director of the CDC. I had served as the ambassador for the global security. The topic I would like to discuss today is about the lessons to be learned in preparation for the next pandemics. I will present the following orders: the introduction and Yes, the learning from the first and the conclusion. But behind the time, I speak Korean now.
As you know, well, the mortality rate was 0.1% globally. Well, this is CFR of ROK, which we take great pride in. But then, how about the surge capacity? Did we have enough surge capacity? That's something that we need to revisit and improve. Now, comparing to the US, the number of patients was about 1/3 and death rate about 1/10. And that really shows that we were quick on our feet in dealing with the patients. Now, let us review what happened in Korea and then think about how we can better prepare for the next pandemic. Now, this is something that I would like to share with you. Recently, Mr. Anthony Fauci talked about 10 lessons learned, and I would like to mention 2 of them. First, we need to expect the unexpected to come up with a plan B. And emerging infections are forever. This is something that we need to keep in mind, and this actually sets the scene for my presentation. Now, as you know, this is IOM from the US, and this was released back in '92. Emerging infections, microbial threats to health in the United States. That is the title of IOM. The reason why I have it here is because they keep talking about the preparedness for surveillance. Then how do we need to be better prepared in terms of surveillance? It talks about AMR as well as multi-drug resistant and so on and so forth. And after this paper came out for 20 years, Dr. Fauci revisited what we have achieved for the past 20 or so years. And then alert system and the surveillance system were some of the findings that Dr. Fauci came up with. And that drills down to PCR and also to have an early surveillance method. And this was published 10 years ago, but were we good enough with our response this time? I'm not sure. Now, when MERS broke out, I met a professor at Georgetown University, and then at the time I asked him a question: what will be the next pandemic? And actually I met Dr. Fauci, and he said, I do not know. Well, at the time, we were not sure what would be the next candidate of pandemic, but other than prototype approach, there's nothing that we can do. That was what Dr. Fauci said. And to better prepare to the next pandemic, we have to rely on the prototype approach. Now, this is what IOM also released. This is the Ebola report. And according to the report, this is the spectrum of disease risk. It's probability of once out of 100 years, and we need to be prepared for that. And that was the proposal of IOM. So those diseases are very rare, but the impact is huge. So the occurrence cycle will be every 100 years. Then how do we need to prepare for those pandemics? And let us look at this slide. Now, the infectious diseases that we see in many countries with high death rate, we researched that. Number 1 was respiratory infections, followed by diarrheal diseases, followed by HIV, AIDS, TB, malaria. And you can see the list for yourself. And if you look at the occurrence regions, number 1 is China, followed by Saudi Arabia, and then Indonesia, Egypt, and so on and so forth. And the list goes on. And 3 decades ago, when I was responsible for influenza, and at the time, Actually, next to Korea, we share borders with China, and we do not know what will happen, which is why we need to be better prepared. And the US CDC helped the China CDC to build its preparedness. And at the time, I talked with one of the experts in this field and tried to predict the future. So as I mentioned, we need to expect the unexpected. Now to dive into the main topic, together learning from the past, we can change the future of global public health. And this was the quote from late J.W. Lee. Now, I would like to talk about the prototype approach, which was briefly mentioned in the previous sessions. Now, if you look at on your left or right, excuse me, now on the bottom right, you see the high potency elements and also what we need to be prepared for are the low and moderate diseases. So that should be our top priority. And this itself is the prototype approach that we need to take. And the key lesson here is all about the vaccine development. Now, as Sunya retired, this is something that she said. So I regret the mask recommendations or protocol, and this received huge criticism because there was no evidence whether or not it is transmitted as we speak via droplets. We did not have evidence of that. So at the time we were wearing masks, but then we recommended from April, and the US was a little bit behind that. It recommended in June. So when we have a novel infectious disease, we have to move fast and close the gap as fast as possible. But how are we going to do that? We need to have the right strategies. In 2020-ish, after COVID hit, I joined the JEE, and then I actually saw a slide there. It's not in here, but the JEE showed us the list, the to-do list. Number 1 was rigorous surveillance, and number 2 was enhanced surveillance, and number 3 was, as we conduct surveillance, we have to observe the clinical characteristics and the drug impact as well as the natural death of the patients, and then look at the clinical trials as well as conduct mass intervention. We need to have these 6 steps which will help us better prepare for the next pandemic, and that slide was quite impressive. So when a novel virus breaks out, we need to reflect on whether we have this preparedness level. And this also means that we need to have the right research capabilities. But I think that it was placed at the back burner for a while. Now, as we conducted the external evaluation through JEE, this is what I learned. This is voluntary basis, so without any incentives, the low-income countries will not receive the investigation. And now, fake and pandemic is different. Like polio is fake, but it's not pandemic, which is why we need a dual-track approach when dealing with fake or pandemic. Fake was very much focused on influenza, which is why we need new regulations. And the pandemic prevention treaty is now underway as a result. And as Professor Tan mentioned before, we have come up with a global health security index, but high level was the US followed by UK. But still, the US had the most number of patients, which brings us to think, was GHSI effective? I think it has some room for improvement. Now, We also need to have response strategies for the early stage. But if you look at IHR 43 clause, all the countries infringed Article 43 and said, well, actually, Article 43 stipulates that borders should not be restricted or controlled, but all the countries closed off their borders. So is it going to be a single approach, or are we going to do like contact tracing? Now, it really depends on the development of a disease. The low-income countries has to focus on the syndrome approach. And for the other remaining countries, they have to go with contact tracing. At the end of the day, what I'm trying to say here is that we need to have the right scenarios. Next. We experienced SARS, influenza, and MERS. And it showed us that we are well prepared in the public health center. We have the clinics, we have the right system, we have isolation beds. Then how about the private sector? It has over 95% of the isolation beds and hospitals. So how to mobilize this resource will be key. But to manage the private sector, we have to change the health coverage system in Korea, which means that we have to bring up the cost, and we also need to promote the inspection and auditing system. And many patients cannot receive care from their family members. So given that situation, they need to be treated as inpatients. But now we have many people traveling overseas, so we have to be better prepared for imported diseases. But in the early days, actually, we did try to do that, which is why Korea performed well in the early days. We focused on the elimination strategy. But now in containing unexpected viruses or higher transmissible toxic virus, actually this had limitations. So as public health intervention level needed to be notched down, then it meant that we had to have a strong infrastructure. And thankfully, Korea had solid infrastructure. Then globally, we have to prepare for the next pandemic. Now, the masks and PPEs and strategic resources, therapeutics and vaccines were controlled. They imposed a ban on the export of those materials, which is something that we should refrain from. But we had many countries who took such an action. So we need to deal with that. And now, how about the remaining 80% of the countries that do not have equal access to these supplies? So scaling up production capacity is critical. Now, it's something that we need to look at when providing supplies. Now, the contact tracing method that we have in place is quite costly if it wants to do perfect isolation or syndrome-based approach. So let's say that if we can reach 70% contact tracing, then our value will drop than the one that you see on the slide. And this is what the researchers claim. And to be able to reach that level, now we need more resources. Now, to enhance borderline control, what we did was taking care of the patients and isolating patients at the borders. And those are the activities, like as we experienced SARS and influenza, we improved that model, and I think that it's something that we should be proud of. And it's a model that we can relay or share with other countries. Now, of course, with respect to NPI, this received much criticism. Now, if you look at the slide, stage 1 is utmost priority, followed by yellow, amber, and then red. And to bring down the value to under 1, these are the steps that we need to take. But we failed to analyze all of these elements and just went with NPI right away, which is why we need to analyze the cost effectiveness and rearrange the priorities. Now, we used to have 5 tiers of NPI in Korea. We then downgraded that or reclassified that into 3-tiered approach. And this is what we need to do in preparing for the next pandemic. Now, in fighting the next pandemic, maybe it's because Koreans follow the government protocols quite well in terms of etiquette or social distancing or other guidelines. Korea or Koreans complied with those measures quite well. Now, early isolation and suppression was a success case in Korea, and going forward, I do believe that these strategies should remain, but we need legal and institutional frameworks and role models should be developed to ensure that we take the right approach, and that includes TTIQ or 3T. And during COVID-19, many services were interrupted, and IT was applied to address that challenge. And there were some countries who asked for help for their emergency situations. Now, ICT technology was of great help to provide uninterrupted services, and this is something that we need to continue on. Now, 95% of the patients, especially the young population, they were asymptomatic. And this led to heated debates. This is why we opened community health centers and provided remote care to those patients. And this was quite similar to the strategy of China. We actually benchmarked their model. But as Mr. Che mentioned, providing healthcare delivery and preventing diseases at the healthcare center level, well, we cannot distinguish the two. And isolation itself can waste huge resources, and I agree with him, which is why we need to come up with better ideas. Now, the primary care clinics actually focused on the isolation approach, which was recommended by the government, but was that effective? Immunization met or reached 95 to 98%, and then isolation was no longer in place. And I believe that by making a quicker decision, we could have prevented some of the waste of the resources. And in carrying out these strategies, I think that we could have directed the resources of the local community and the healthcare professionals to take care of other important matters. Now, the public sector was fully responsible for this work, and then once the capacity was not there, everybody collapsed. Which is why when it comes to controlling infectious diseases, we need better strategies. Now, about collateral damage, we talk a lot about this because we are flooded by patients, especially that led to the death of the chronic disease patients because they failed to receive treatment or care. And we need to come up with strategies in terms of how we can reduce the inflow of inpatients or visiting patients. So, which is why we need to work on this syndemic point of view, and I think that we have areas of improvement here. Now, moving on to the next slide, we also had to suffer the waste of healthcare workers. What I mean by that is for a longer period of time, schools had to shut down, and that led to poor quality of training. And that resulted in a flush of professional workers who were not fully qualified to do this job. So the health education and nurse education needs to do better. For instance, everything has to be based on competencies so that they are flexible and they can adapt to all the situations. So I have a photo or image of an adapter here, which is why this is because I believe that nurses and healthcare professionals need to perform the role of an adapter. They need to cooperate with the local communities, they need to exercise leadership, and they also need to work with one another and really lead by example. But we saw silo during COVID-19, which is why we need to actually break that vicious cycle and do better next time. And this is something that we can apply to the resident training course. Now, moving on to immunization. This is something that requires an examination because when it was less viral, we started immunization, but some virologists say that, well, actually, it wasn't the immunization itself that was effective, but the virus that lost its virus toxicity. So now, the WHO did not focus on the high-risk group from the get-go. It actually widened its coverage, and I think that was a mistake. So the prioritization, the priorities should be set differently. Now, and we also experienced the confusion because there was this idea of herd immunity, and there were people who said we need to use immunization to reach herd immunity, which I think was a mistake. And the concept of classical herd immunity did not apply to COVID-19. So these are some areas that we need to improve. Now, we also need to improve the governance of the COVID-19 pandemic. Of course, the WHO exercised leadership, but now the lack or failure to comply with IHR and the weak compliance and poor fund and verification were exposed as problems. And now China has its One Road, One Belt initiative in place. And now that actually helped us, and also the Alliance for Multilateralism helped us as well. Now for vaccines, we used the bilateral alliance to develop vaccines, but at the end of the day, it all drills down to your financial capacity. So whether or not you're financially equipped to carry out these projects is something that will determine the output. Now, we took a dual approach. So we had IHR and WHO CA+. Now, the pandemic treaty spans across a wide scope, which entails a lot of difficulties in terms of what elements are we going to incorporate into the treaty. So I'm not sure whether we will be able to meet the deadline in coming up with the first edition of the treaty. Anyways, so by doing better and improving what I just mentioned, I think that we can do better in the future. And Professor Goldstein proposed most of these ideas that I have on the slides because we have public health, medical care, and social health care, and we need to strike a balance between these elements. And the problem here is that we need to have the right policies in place, and the policies have to be evidence-based. And that needs to gain the trust of the public, and it needs to be incorporated into policies and then really gain momentum. So at the end of the day, the database should be evidence-based. And the medical approach, the public approach, and the social approach will be aligned and work successfully. But we have to take human rights into consideration, and R&D is also a key pillar that underpins this idea. And I talked about the infection-focused approach, and especially for COVID-19, we talked about the indoor, and we also had like foci in the other countries like Africa. Anyways, we have to work hand in hand. We also need a strong governance. And to secure a good governance, decisions should be made in a transparent fashion, and it has to be committee-centered, which will gain the trust of the public, and the policies will become effective as well. Thank you very much for your time. Yes, thank you very much, Professor Lee, for the wonderful presentation. You talked about the principles that we need to comply with, and also you outlined some of the elements that we should take care of as we prepare for the next pandemic, and you also drew lessons from the COVID-19 situation. And next, we will move on to the expert presentation. 4 presenters will speak. Now, I would like to introduce the first speaker, who is Dr. Tak Sang-woo.
박수로 맞이해 주시기 바랍니다.
Please welcome him with a big round of applause.
정은경 청장.
Commissioner Chung, well, former Commissioner Chung, I hope you are okay.
I speak Korean beautifully, but I talk faster in English. So here I come. I'm only given 10 minutes, but I can talk about this topic for all day long. But here I come. I'm going to talk about some of the efforts we are making at the KDCA, especially regarding the global health disease surveillance and also risk assessment. My name is Sang-woo Tak. I'm the Division Director of Risk Assessment, and I see a lot of great minds here. I'm going to pretend that I'm going to be one of them. So I don't know how good I'd be pretending this. So I show this chart a lot of times. When you see this chart on your right, on your left, you see the increase since I don't know, 2011, 12. But it's not coincidence when you look at the PubMed and search the keywords event-based surveillance. Since WHO published this guideline to establish event-based surveillance at each member state in 2008, it has increased. A number of publication went up. So I don't think it has to do fully with event-based surveillance established in each member state, but it has a lot to do with the system. If you look at the IEHR scores, when they examine the national capacities of surveillance and other critical aspects, such as coordination and response, preparedness, if you see the table, it's published in 2020, and the surveillance is the core capacity that has the highest rank among those, meaning that most of the countries are prepared with the surveillance capacity. But if you look at the chart, when we saw this chart all the time, I mean, in the past 3 years, we learned a lot about surveillance. But as you can see on your left, France and South Korea has the highest incidence, whereas lower, middle, and income countries have very low incidence rate. Is it because Korean people or French people are weaker in their immunity? Probably not. It's because we found more people, we found more cases. And if you look at the case fatality rate, South Korea has probably the lowest, among the lowest, which means that we found more cases in the denominator, which gives very low case fatality rate. So I think the case fatality rate is one of the indicators of surveillance capacity. So looking at the same disparity that we saw in the past, it's not promising. World is complicated, and we interact a lot to achieve a perfection. Perfection in controlling disease and health problems in anywhere in the world. And we talk about the data to communicate and interact, and so we can act on such an information. But we are living in this age of complexity. So how do we achieve this perfection? What we're trying to do as a national organization, some of the things that we do is to develop a machine learning tools or AI-related event-based surveillance tools. And we use artificial intelligence, machine learning. We're trying to use web crawling and crowdsourcing, all kinds that our other countries or peoples are using. We are also trying to develop a platform that integrates all kinds of different health informations. And we use One Health program, and we had several biosurveillance related projects. We even tried to develop like syndromic surveillance program. We're also trying to expand our informal network to communicate with other countries, especially when it comes to surveillance information. To achieve these goals, we see a lot of challenges we have to overcome. One of the organizational challenges is about the awareness among the leaders and policymakers. When we talk about global disease surveillance, we often face this claim that we are busy with internal and domestic issues already. We can work on the domestic surveillance. When they come in, we can tackle it. Why do we have to spend more time and energy to come up with this global disease outbreak surveillance? Facing this kind of claim is very typical, and I have to go back and why we need to work together to achieve the perfections in global disease surveillance and prevention. And we often think about if we can have highly sophisticated machine-based information tool, such as AI tools, it'll be all set. But it's not true. We have to understand how we are going to use these machines and tools so we can have effective method to utilize that that helps our preventive measures. So I say, setting the clear goal for that kind of sophisticated tool is priority. And we also have to have some sort of collective awareness about the epidemic intelligence. When we have this kind of epidemic intelligence, we often think that as soon as we detect that information, detect the outbreak information, we'll be better off. But what do we do when they have that kind of information? If we say, look, we found something that's fishy and suspicious in country A and B, and what do? We don't know what to do because there are a lot of uncertainties, and we have to understand we work with this uncertainty when we talk about the surveillance. So detecting the signal in the early phase is important, but detecting it with certainty is probably more important. In achieving those goals, we also have some of the operational challenges because, like I told you, information that we collect is based on a lot of uncertain information. So we have to think about what we do. And also, when we have that kind of information, it could be false positive, and we have to understand how much false positive we can endure, we can tolerate in terms of organizational capacity. We have limited budget and workforce. We cannot send out all the people we have to make sure that positives are all false or that positive signals are all nothing. So we have to understand in which level we have to make sure that we respond to that kind of information. And we talk about workforce development in the future, but we're talking about data scientists. Because we try to use these tools, we have to understand how we can develop data scientists linked with surveillance activities. So maybe we can use field epidemiologists in the development program, and during their training, we can talk about data science, or we can recruit data scientists to make sure that they understand field epidemiology and surveillance. So we didn't talk about that, so we have to start discussing how we achieve this. Global surveillance or global disease surveillance requires a lot of coordination, and I don't think just a few countries with the advanced technologies and capacity, I don't think we're better off preparing for next pandemic or next fake or whatever that world is going to be shaken. I suggest that we have to have a lot of tabletop exercise or similar exercises with those countries, learning from their lessons. We talk about we learned lessons, but what lessons have we learned? And I think we need to put it on the table so other countries can learn exactly and specifically, and so they can prepare for the next pandemic and future, a fake event. And we say we have to invest more in getting the primary data or information, so we can have this outbreak information used for our decision-making process, and that process is also enhanced by. My time is up, so I'm going to be spending 2 minutes. Sorry about that. So here are 4 things that I think we need to think about as the requirements for national public health institutes that are working on global health surveillance and epidemic intelligence. We have to have information. If we don't have any information or information needs, we don't know what to collect. And once you collected the data and the information, you have to have a certain process or protocol to interpret the result that you analyzed. And the interpretation is not enough. You have to have the certain validation for that information you can act on. So it has to be very effective and sustainable. You cannot send all the people or spend all the money and budget on validating that information. Maybe that information is false. Once you validated it, you have nothing to do. And prediction, I'm not talking about the mathematical prediction. I'm talking about, learning from the past, this accumulated knowledge and experience, you can predict based on your situational awareness. That way you can prepare better for the future. Maybe there are certain things that we can work together, and one of the things is that we can actually spend more energy to increase our outbreak information exchange through certain network or something like GeoSentinel. And we have to have a certain platform so we can act and exchange that information. I always say that we need more people on the ground because we can only see things where we look. If we don't look, we don't know what's there. So to make sure that there is nothing, we have to have a certain eyes on the field. And we have to send more people. So more boots on the ground. I think that's very critical. Here are some things that are in progress in Korea Disease Control and Prevention. We're going to have Global Health Security Coordination Office pretty soon. We're working on that. And we are trying to establish a global disease surveillance center within that organization. It's still work in progress. And KDCA is already a WHO collaborating center, but we're trying to play another role as a pandemic and preparedness response leader. And we are trying to expand some of the official development assistance funds to include more people, more countries. And also we are conceiving a role that we could probably play in the future as a regional hub for future pandemic and epidemic. That'll be my talk. Thank you.
Thank you very much, Dr. Sang-woo Tak, for giving us some challenges and how to tackle such challenges. It's a great talk. So I'd like to invite the next speaker, Professor Mei-Fong Mei-Sei. Let me introduce him briefly. He's a professor of the University of Health Science, Lao PDR. Dr. Mei-Fong, are you online?
Yes.
Okay, please.
Thank you. Okay, thank you very much for inviting me to share our experience on how we responded and what we have learned from COVID-19 pandemic in our country. During the year 2020, the outbreak in many countries in the region and worldwide was number of COVID-19 cases. Laos as a country with very low reported number of cases. And we were the last country in Southeast Asia with confirmed case of COVID-19 on March 24, 2020. However, many people are still suspicious whether this is true or not. For example, there is a paper published in the Lancet Regional Health Western Pacific raising a question. Did Laos really control the transmission of COVID-19? In addition, the people from a neighboring country claimed that Laos did not have lab capacity to identify COVID-19. Therefore, the number of cases remained very low. Actually, COVID-19 was very well controlled in early 2020. It's first evidenced by the result from a zero prevalence study, which demonstrated that there was no evidence of significant COVID-19 circulation before September 2020. So what would this happen? I think that early decisive action taken by the government was probably the key which lead to the initial success of controlling COVID-19 in the country. After the identification of 9 cases by the end of March 2020, and after the rapid spreading outbreak in neighboring Thailand, the government established a lockdown on 30th March, banning international travel and mandating testing and quarantine of incoming visitors and migrants. The National Task Force Committee led by the Prime Minister was established. control and prevent the pandemic. At the same time, the Emergency Operation Centers, or EOCs, were also established for daily report of the situation and to provide daily communication. The stronghold government coordination, excellent collaboration with development partners and international organizations with very specific and clear responsibilities was another key to success. The government also strongly engaged the community to strictly implement public health measures while strengthening the case detection and management at all levels of health facilities. Additionally, multi-source surveillance was implemented in order to ensure early detection and evidence-based outbreak response. With all effort and hard work, by June 20, the government declared victory against COVID-19 following the discharge of all patients with COVID-19 from hospitals, reporting no new cases for 2 months. Since then, there was a small number of new cases reported, and after keeping daily incidence below 50 cases for a long period, the number of infections spiked thousands and the number of deaths to a few hundred. New clusters were linked to scenario in the Golden Triangle border zone every country. Migrant workers who had returned from Thailand and the Lao New Year celebration in the middle of April 2021. The recurrence of outbreaks provide the public health community with an important lesson that no system is completely secure and that contingency planning and emergency preparedness need to be implemented for any upcoming pandemic. During the fight against the pandemic, we were facing with a significant shortage of healthcare professionals. Therefore, medical and paramedical students were encouraged to assist and help with many activities, such as screening the entrance at checkpoints, providing care to patients, operating hotline correspondence, helping with COVID-19 vaccination, and etc. With that, we have realized that the pre-service trainings are extremely important. Therefore, we have now incorporated some training courses such as immunization into the university curriculum in order to be prepared for any future emergency scenario. The government also took COVID-19 as an opportunity to strengthen healthcare and community engagement by implementing some new initiative health projects. Which stands for Community Network Engagement for Essential Healthcare and COVID-19 Response through Trust is one example. It is a multi-sectoral initiative with Ministry of Health as the main technical agency and Ministry of Home Affairs leading the engagement with local governance structure. This new initiative helps us to achieve shared ownership of local authorities in primary healthcare and the unprecedented attention gained to health of community now help us to look beyond COVID-19. As a result, there has been a significant increment of healthcare service uptake, especially ANC in many health facilities. Summary. What we have learned from the control of COVID-19 pandemic in Laos are that, first, early decisive action by the government together with strong multi-sectoral collaboration and coordination, as well as engaging communities together with strengthening surveillance system at all levels play an important role in the well-controlled pandemic COVID-19 early 2020 in Laos. Secondly, no system is completely secure. We need to have a contingency planning and emergency preparedness for future pandemics. Thirdly, students can be a solution for the shortage of healthcare professionals during the fight against the pandemic. Fourthly, pandemic can be an opportunity to strengthen healthcare system in the country. And lastly, we need to adapt COVID-19 response to a more sustainable long-term approach while remaining vigilant in detecting re-emerging of any infection in the future. Thank you very much for your attention.
Thank you, Professor Mei Fong, for sharing us how Lao PDR respond to COVID-19. This is a really rare opportunity to learn about one of the ASEAN countries responded to COVID-19. I'd like to move on next presentation. I'd like to introduce the next speaker, Dr. Park Gun-hee. He is currently Director General of Pyeongchang County Health and Medical Center. I think he's on the line, so please show his presentation.
Okay, thank you, Mr. Chair, and good afternoon, everybody. My name is Gun-hee Park. I'm currently working as a Director General, one of the districts in Korea. We have about 250 district or county, and I'm currently in charge of one of the county. And then during the COVID-19 period, response period, I used to work for the Director General of District Level Director General, as well as I moved to the provincial level as a Director of Infectious Disease Control. So using my experience working at provincial level and district level, I'm going to make a short presentation. Since all of you must be very hungry and even tired, so I'm going to make my presentation very short. So this is quick overview of the role of central level, provincial level, and district level. Most of these policies developed at the national level, but implemented at the district level. And then province more or less coordination and technical support. And in Korea, we have the public health system and medical care system a little bit divided. So the district health authority and provincial health bureau in charge of public health system. And then for the medical service, such as treatment, mostly delivered by the hospital and the clinics. In Korea, about 90% of health facilities are owned by non-profit private sector, not public sector. But financially, national health insurance, cover this medical care system. But at the district level, this district health office and then clinics and hospital, they were have worked together to respond to COVID-19. And in Korea, from the beginning of the pandemic, the Korean Ministry of Health and the Center for Disease Control developed this guideline for local government. In the beginning, the first edition was about 20 or 30 pages, very thin. But now it's about 13th edition, and the page is more than 200 or 300, very thick guideline. According to the guideline, the role of province government is surveillance, risk communication, epidemiological investigation, and supervision of district level epidemiological investigation. And in the beginning, maybe for about 2 years of the early stage of COVID-19 response, before the Omicron variant, spread, most of treatment was coordinated and handled by provincial level. But after Omicron variant, since the number of patients has been increased very, largely and quickly, then the treatment moved from the facility-based to the home-based care. Once it moved to the home-based care, the role of treatment, the coordination of treatment moved also from province to district level. But before that, provincial level mostly in charge of COVID-19 treatment coordination. And for the vaccination, the delivery of planning and delivery of vaccination on the district level. However, in terms of adverse event, surveillance, investigation, and compensation was also provincial level in collaboration with the national level. The district level, their role more like a surveillance, risk communication, coordination of testing and contact tracing and quarantine management and vaccination program, social distancing policy, and local level resource mobilization was district level, the responsibility, role and responsibility. In the beginning of today's session, there are like a TTIQ, test, trace, isolation, and quarantine. Most of the success story of TTIQ in Korea, under the role of district health officers. They are working very hard. They were working very hard to, from test and the contact tracing and self-quarantine management, mostly under the district level officers role. So in order to provide this role, the organogram of province and district level has been changed. Before COVID-19, only 5 departments under the provincial health bureau in Gyeonggi province, one of the biggest province in Korea. But now it has 7 departments, which include infectious disease control, which I was the director until January this year. And then we created, public medical care department, which is in charge of public, hospital to provide more the quality treatment to the patient. And the district level, same. District level, the health officer used to have 2 departments. One is health policy, the other one health promotion. But during the COVID-19 period, this division has been changed. One for response team, the other for supporting team. And supporting team in charge of clinics and self-quarantine, call center, and vaccination. And response team working with mostly the surveillance and the contact tracing. These are one of the examples, but most of the 250 district health offices has changed, their organogram to respond to the COVID-19 pandemic. This is a quick overview of what has been done for the contact tracing. Maybe you might have experience about this one. So once the case detected or confirmed from the test, then initial case investigation and organizing contact tracing team and identifying close contact and then releasing case information to the public and monitoring the contact. This is the pathway of our work for the contact tracing and self-quarantine management. And then we use this kind of messenger program or electronic services, the CCTV to find out the close contact, and then disinfect this, the facilities or places to prevent further spread. And then last might be the second last slide about the adverse event after vaccination. This is also role of district and provincial level. So report from patient family health facility to district health office. After initial investigations, report to the provincial level. And provincial level conducted detailed investigation. And provincial level, we also organize this professional review committee to review the causality of the adverse event. Then we have tentative, our judgment to submit to the national level. Then national central CDC, they organized the national committee to review and confirm the causality of the adverse event. This is the workflow of the adverse event after the COVID-19 vaccination. This is also role of kind of surveillance role of district and provincial level in Korea. And routine surveillance after COVID-19, currently, for example, Gyeonggi province, they have, this COVID-19 surveillance system and other notifiable disease surveillance system and dashboard kind of things. And then after COVID-19, the pandemic, Korea like to launch new surveillance systems such as zero surveillance and wastewater surveillance system. This is all of my presentation. If you have time, you may click this link, about 7-minute, YouTube video about the reality of the district level officers, work in Korea during the COVID-19 pandemic. Thanks for your attention.
Thank you very much, Dr. Connie Park, for sharing us from your experience in the fieldwork. That was just so nice and valuable. I'm going to move to next speaker, the last, but never the least presentation of this session. The Professor Oh Joo-han is the Professor of Seoul National University College of Medicine. Please.
Yeah, thank you, Chair. Let me introduce the importance of the digital technology adoption for the future pandemic. We know that the TTIQ is very much important to reduce the transmission, as our previous presenters, keynote speakers, speak very well. Although we expected that very well, the empirical evidence is not that much high in terms of number of publication. However, Lancet recently published a systematic review of the small number of publications that shows a high importance and a high association between the TTIQ function and the reducing capacity of the incidence of mortality. Let me add the more strong the evidence from the South Korea now. Then we can see the first year's experience of South Korea. Then high performing quarantine performance can predict 1 week later low incidence of COVID-19. That was consistent for the first first years. Then if we translate into the mortality again, then we're using the 2 weeks more lag, then still the higher function of the quarantine, then that can predict the low mortality in 3 weeks. So that how important TTIQ, we know. Then also if we measure differently, using the test ratio, negative test ratio can be higher when we go to the higher performing TTIQ normally. Some of them are negative, but during the quarantine period, that can be changed into positive, while the others are still kept as a negative. So that positive number of the population which are infected but early detected and quarantined can be the secret of the reducing of the transmission. So also the negative tracer measured quarantine activity and then contact tracing based quarantine capacity is high, then low incidence can be predicted. That is the empirical evidence of Korea. For the second year of the pandemic, when vaccine is available for the world, then still we don't see the no relationship, no association between TTIQ function and incidence or TTIQ function and mortality, partly because the imperfect vaccines transmission cutting capacity. So that when you see the low vaccine coverage countries, the cumulative incidence of the second year, 2021, of the pandemic, and the mortality, cumulative mortality, and that shows still the higher TTIQ function show the low mortality, while the green country, which has a higher vaccine coverage countries, still shows the negative association. So the higher TTIQ function still guarantee the low mortality or incidence, partly because the complement nature of the imperfect vaccine. So TTIQ function is so important like this. Then timely scale up to TTIQ capacity, that can be matter as especially against the surgery. As in the morning session, the Dr. Tong-Young Chung, which is General Director of the KDAC, wisely mentioned that future preparedness is important in terms of number 5. He mentioned the human resource capacity increasing, slide scale increasing to combat surgery. That was mentioned, and the precise number was also utilized. So that when we see the surgery in the 2021, the last second half of the second year, we experienced the surging of the viral transmission. However, human resources, the countermeasure in terms of scaling up of the human resource workforce was not done very well because there is many reasons, but that was not easy at that time. So inevitably, we experienced much more increasing mortality, excess mortality from then. Then the green period, that is the one KDAX experimental pilot in one city in South Korea. Let me show that result. Then before going that, during that second half of the pandemic, South Korea experienced a reduced capacity of contact tracing over time for the last 6 months. From the beginning, at July 1st, for example, that shows a higher capacity. Once we find out one cases of the patient, then we can find out contact tracing, find out about 30 or 40 contact that will be quarantined. The maximum was 60 and the minimum was 5 at that time, but that was continuously reduced over time for the coming 6 months until December. That was showing that about 5 or 3 per one case of finding in terms of quarantine. So that lost it means that we incrementally lost the TTIQ function, which is secret of the success of Korea. Then still we are having so much good relationship between the TTIQ function and then incidence of mortality during this time. So if we are successful to increase the human resources or other digitally adaptable new option, which can be TTIQ digital, if that is accepted very timely, then we may have different result. So the Suwon city was collaborated with the KDAC at that time for develop the experimental devices. Then we had one new device at that time. Then from the 11th November, then Governor of Suwon adopted this the technology, digital tracing technology, then exposure notification services for the cell phone users who downloaded this application. Then next month, the December, it showed the markedly decreasing of the incidences. That is statistically significant. And then second month, the January of the 2023, also showed the markedly decreased incidences. But after that, next month, the 2022, the February, nationally, the epidemic is so high, so eventually KDAC declared no more quarantine because of the high incidence of the quarantine, which cannot be maintained at national level. So that Suwon city was not exception, so inevitably Suwon discontinued this digital tracing app-based quarantine. Then it showed resumed to be same as other district. So if we see the 1 month by 1 month more in detail, then we actually compared with the other districts in the same provinces, which show the parallel trend before this adaptation of digital tracing technique. Then, as you can see, left upper, the first month no changes, but the beginning months, but upper light, the December, there is the first month of the adaptation. Then it showed the decreased one. The lower diamond is the summarized the statistical distribution. Then the second month after adopting the digital technique, the lower left that show the diamond is left statistically significant, but that was recovered, eventually became same as at the reference district after finishing the quarantine. So the quarantine digital technique is the basis of this contact information between the patient mobility information and then cell phone users' own information. So that if there is an overlap, that is notified. So that early notification can make the people voluntarily quarantined and voluntarily tested. So that is a timely cutting of the transmission can be possible by this way. Then one of the concerns to the privacy was then pervasive in the world. Then this new application was one of the innovative techniques utilizing the mathematical one that we call that homomorphic encryption. There is a very complex mathematical way, however, that was utilized. Then it eventually, during the calculation of the overlap of the patient mobility information and then cell phone users information, they don't need any decryption, so that no information or no privacy information can be leaked. So that this is the secret of this very privacy preserving applications. So using that, we need to concern the people's privacy concern. Then privacy preserving digital technique, if that is available and then if that is acknowledged very well widely, and people can trust government supported digital technologies that will decrease and then cut the transmission as Suwon city empirically showed. So the scale up of this new technology, which can preserve the privacy, can be one of the new digital technology option for the next pandemic. Thank you.
Professor Juano for sharing us the why we need to take the data-based approach and advantage of the adoption of digital techniques to improve surveillance. So that is a really nice talk. So now we are reaching the final segment of today's seminar, the panel discussion. In this panel discussion, we will have three panelists from three countries of ASEAN. Professor Sanjay Rampal from University of Malaysia, Professor Budi Hiranto from University Indonesia, Professor Panwich Kekam Joncha from Mahidol University, Thailand. So the first three, I'd like to invite Professor Sanjay from video presentation.
Good afternoon. My name is Dr. Sanjay Rampal. I'm the Deputy Dean of Research and a Professor of Epidemiology and Public Health Medicine at the Faculty of Medicine, University Malaya. I'll be presenting to you today on building resilience in a post-COVID-19 era, the Malaysian experience. Now, this is a very busy slide, but an important slide nevertheless. The top image here shows you the epidemic curve, followed by the test positivity ratio, the genomic sequences that we have, and the NPI intensities, with a red denoting a very intensive form implementation of the NPI, and green meaning lesser implementation of the NPI. Now, a very important part of the epidemic curve is this wave, and this wave that we had was also known as a delta wave. And the delta wave was important because it heavily strained our health resources with very high utilization of basically our hospital beds and ICU. However, at the same point of time, we had instituted the National Immunization Program. With the National Immunization Program, the number of new reported cases had decreased, and subsequently we have had waves of the Omicron variants. However, an important point is in a post-vaccinated population, the effect of the Omicron waves have been substantially lower on our healthcare resources, using substantially lower amount of healthcare beds, hospital beds, and ICU. Now, one important point about the COVID-19 was, in order for better prevention and control of COVID-19, we had developed the MySejahtera app. The MySejahtera app, when it was initially developed, was for contact tracing. However, it had expanded in order to encompass the full range of prevention and control activities, including testing, contact tracing, isolation, quarantine. And later on, we also added features such as the digital certification for COVID-19 vaccination. You can also perform a self-reported health assessment, giving you your risk status. And subsequently, whenever you go to any central labs and get your blood tested for COVID-19, the results are kept in this app for a period of time. Following the pandemic era, then what has happened is we have converted the app from just being an app solely for COVID-19 into a health super app. So there are plans to incorporate lifetime health records into the app. And at the same time, we have also added on an infectious disease tracker. That means this basically tells you the new reported number of cases of tuberculosis, COVID-19, and foot and mouth disease, dengue, animal and human rabies, and measles. And the list of diseases that are tracked by this app are reviewed periodically. In addition to that, the app also provides information and support for travelers. It also helps you manage your dependents. Now, one important point about the app is, with further development of the app has been used now for primary healthcare, for delivery of primary healthcare services, where any Malaysian resident can go to the app and can schedule an appointment for the various available services that we have at the primary healthcare clinic. Now, another important development that has occurred is the health white paper for Malaysia, strengthening people's health, future-proofing the nation's health system. Because one important point that we had learned from a very important lesson from COVID was that we needed a more resilient health system. So there are 4 pillars to this health white paper: transforming health services delivery, advancing health promotion and disease prevention, ensuring sustainable and equitable health financing, strengthening the health system's foundations and governance. Now, specific for pandemic preparedness, the second pillar addresses the need to build a national CDC and also to link up our labs that we have in the MOH and in the private into a network of centralized lab reporting systems. In addition to that, I think it's very important to note that we have at the same time to address comorbid factors. That means factors that can increase disease severity of future pandemics or future diseases. So one important factor is smoking. And during COVID, during the pandemic, we had tried to institute the generational endgame. However, there was a lot of opposition from the politicians, and so it has been postponed to this year. As you can see from the survey performed, right, a majority of Malaysian participants who have responded to the survey agreed with the proposal of the control of tobacco products and smoking bill 2023 right now, actually. And the idea here is to prevent future generations from ever starting to smoke or to vape. So with this, I have presented a brief overview of COVID-19 as it was, and also future plans that we are taking in Malaysia to prepare for the next pandemic, which is number 1, building a more resilient health system, and number 2, addressing factors which may increase disease severity of future pandemics. With that, I would like to thank you for your attention. Thank you.
Thank you, Professor Sanjay, for sharing us Malaysian experience tackling COVID-19. So I would like to invite next the panelist, Professor Panwich from Thailand. Professor Panwich, your turn now.
Hello everyone, I'm Panwich Kamchonchai. I am a health policy and system researcher and a health system science lecturer at Rama Tibodi Medical School, Bangkok, Thailand. First of all, thank you for having me here. I'm going to give you a brief lesson learned based on our experience during the COVID-19 pandemic. As you can see in this slide, Thailand handled the first wave of COVID-19 pandemic quite well in early 2020. The New York Times noted that the world wasn't quite sure of Thailand's approach at that time, but it worked effectively. Without optimal data and information, our government implemented strict policies against COVID-19, including a lockdown in the Bangkok metropolitan area and a curfew that affected both private businesses and most government services. However, let me give you some insight. As you see in lower left photo, the Bangkok shutdown, including the curfew declaration, resulted in both intended and numerous unintended consequences. The Bangkok shutdown policy was announced just a few days before the Songkran festival in April. Traveling across the provinces was not banned at that time, given that many Bangkok residents originally come from other regions. Following the announcement of the shutdown, a significant portion of the population traveled to their hometowns using congested public transportation. Prior to this, the COVID-19 outbreak was largely concentrated in Bangkok, but after the Bangkok curfew was put in place, the outbreak spread nationwide. Based on the lesson learned from the unintended consequences of policy decision, our team later published this article. Not only did the lockdown and curfew policies have unintended consequences that led to spread of COVID-19 nationwide, but the strict lockdown and curfew policy also had a profound negative impact on Thailand's economy. Given that significant portion of Thailand's GDP comes from tourism, which includes sectors like hospitality and transportation, a lockdown policy without a comprehensive plan to support the tourism sectors resulted in an increase in unemployment. As shown in the picture above, unemployment created hardships for informal employees in both Bangkok and other provinces. Furthermore, while COVID-19 and policy decisions affect the economy, there was also feedback loop from the economic situation impacting COVID-19 outbreaks. Without the means to sustain their daily lives, the low-income population couldn't adhere to national recommendations and regulations, particularly regarding personal protection and hygiene. This resulted in challenges controlling the pandemic. So as I mentioned earlier, this graph displays the number of new daily reported infections in Thailand. As you can observe, during the first wave, we did excellent job. The number of new cases remained relatively flat, especially when compared to the second wave and the third wave brought by the Delta variant, then fourth wave of Omicron variant. Interestingly, we implemented a curfew and lockdown policy during the first wave. However, despite the significantly greater number of infections and skyrocketing death toll during the Omicron wave, we couldn't adopt the same approach. The question is why? Why did we enforce such strict policies during the smaller first wave but not for the subsequent waves? It's because stakeholders and general population grew fatigued. Certain groups began to feel some degree of resistance against these policies. People became increasingly concerned about socio-economic impact on their families, communities, and businesses. Let's move to good story we did. Looking back at COVID-19, all policymakers had a good intention to combat it. But there is always room for improvement. To overcome the negative consequences of using strong policies against COVID-19, the system thinking approach serves as effective tool. It allows for engage with related stakeholders and synthesizes policy recommendations in a context filled with uncertainties. After first wave of COVID, our team consisting of epidemiologists, medical specialists, health policy and system researchers, also modeler and expert from social economic sector embarked on modeling process to assess and predict pandemic scenarios. Also, the dashboard that aggregated and visualized the indicators related to pandemic was developed by Ministry of Public Health. Apart from real-time surveillance that allow the stakeholder to get real-time information, we also apply modeling to predict situation in multiple what-if scenarios, as you see in the left. Moreover, system dynamics modeling were not only used as decision support tools for the Ministry of Public Health in upper picture, but also for public communication in the below pictures. From the complex SEIR model, we utilize its call structure to communicate directly with the public through mass media. So surprisingly, we received positive feedback. Many found that simplified SEIR model effectively demonstrate the mechanics of an outbreak, and this clarified inspired various stakeholders, especially those from private sector, to understood how they could contribute during the pandemic. For instance, some entities introduced and provided isolation units, commonly referred to as hospital, which with the term is combining hotels and hospitals. Apart from using system thinking pandemic dashboard, the data platform and application Moprom, which translate to a Doctor Get Ready application, was quickly developed. Most Thai people and migrants in Thailand own mobile phones, and our cellular data is actually quite affordable. With this application and data platform, individuals can schedule COVID-19 vaccinations, COVID-19 tests, and search for isolation centers and request medical assistance during the pandemic. Moreover, the ministry received valuable data on vaccine coverage, the number of infection and test results. Before coming to this application, we use a telephone call or hotline for people to call if they need any information or assistance, and resulted in congestion of call. During COVID-19, the application underwent numerous updates. As the outbreak subsides now, this application and data platform remain in place, receiving regular updates. The ministry now uses Moprom application not only for the COVID-19 situation, but also to support the concept of personal health data. People can schedule essential preventive and health promotion programs, such as checkup, mental health screening. This serves as an example of how COVID-19 crisis has accelerated our efforts to implement digital health for a more resilient and accessible health systems. To sum up, we face a great deal of uncertainty, complexity, and dynamic change in the situation. We lack knowledge and essential information at that time. This scenario might have led to the decision to respond aggressively to the outbreak, resulting in some unintended consequences and negative consequences, even though there were also positive outcomes. However, what we have learned is the system thinking and effective engagement with relevant stakeholders, we were able to navigate the situation more adeptly. Additionally, understanding the dynamic of outbreak and investigating in testing, tracing, and isolation according to the epidemiological principles is a high leverage point strategy. Last but not least, proper surveillance information system together with the method of system dynamic modeling prove invaluable in predicting outbreak trend, especially during the period when information is scarce. But in the order to make accurate model to support better policy decision, the information platform which can aggregate essential data such as the number of cases and available resources should be invested and made prior to next crisis. Thank you.
Thank you very much, Professor Panwich, for sharing us your experience for tackling COVID-19 and what you have learned from the lessons. Unfortunately, we lost the connection with Professor Budi from University of Indonesia. So I think we need to close this last segment of panel discussion. But before closing, we actually shared experience and lessons from some countries from ASEAN. I found that the more similarities than differences. So I think that would be really a foundation why we work together to build on surveillance system or the pandemic response system. So from this experience and from this exchange of ideas, the concepts, and the lessons, I think that we can move forward to another level. So I think that is a lesson we learned today. Actually, I'd like to say I'm sorry not to have an active discussion part in this section and discussion, but because of time constraint, we need to close this session. Please.
네, 고맙습니다. 우리 홍윤철.
Thank you very much, moderator Professor Hong, for wrapping up this session and leading the session very well. Let's give all of them a big round of applause. Yes, I think I was really impressed with the last remarks of our professor, which was that we have more commonalities than differences, and that is precisely why we need to work together amongst ourselves. I hope that we will have more gatherings like this today so that we can join our heads to find ways forward together. Ladies and gentlemen, this brings us to the end of the 2023 ASEAN-ROK Infectious Disease Conference, co-organized by KDCA and the mission of ROK to ASEAN and the ASEAN Secretariat. We were short of time, and I hope that you would be kind enough to understand that we had to rush through. And I want to thank all of you here in the venue also joining us virtually. We do have the QR code here, so if you can fill out the questionnaire, we'd be greatly appreciative. And also QR code can be also offered to you here at the venue with us in Seoul. And please also use this QR code here on the screen or in the back of your name tag. Please do participate in the questionnaire. Your inputs would be very useful for us to build even better structure for next round of this conference. I just want to let you know, those that do participate in the conference survey, some of you will also be lucky enough to get the coupons for the free coffee. Ladies and gentlemen, I want to thank all of you for your great valuable insights on the innovative ways forward and how we better prepare ourselves for the pandemic that might arise in the future. I want to thank all of your great engagement, and thank you so much for staying with us until the very, very end. It's been a long day. Once again, thank you all very much here in Seoul with us and also joining us virtually. And I also want to give my special thanks to the moderators and the speakers and the keynote speakers as well. Ladies and gentlemen, have a safe way back home, and this really is the end of our conference. Thank you all very much. My name is Kim Yeonjin. It's been an honor and pleasure. Thank you and bye-bye.